start with the first session. My name is Aisha Dhaferi. I'm a consultant psychiatrist and the chairperson of psychiatric department at Sheikh Khalifa Medical City Sahha. This session will consist of 3 lectures, each for 15 minutes. All of them are around the theme of mental health services, model of care, and challenges. We'll start with the first one, supposed to be presented by Dr. Hadir, but she could not make it. So the first lecture is about mental health services during the COVID pandemic. It's an example of our experience in behavioral science pavilion dealing with the unprecedented changes of COVID pandemic. So I'll do it. So Hadir will not be here, I'll do it. So this is a short report we prepared with my team, our psychologist, social worker, and psychiatrist to present to the world our experience in Abu Dhabi dealing with COVID. How did we relocate services? How did we relocate staffs, and done a lot of changes in the structure to deal with COVID pandemic early on. Green button. Okay, so we all know that World Health Organization declared the corona disease outbreak pandemic in March 2020. The Middle East first confirmed COVID case was in January 2020, and that was in the United Arab Emirates. So here we're trying to demonstrate a model to the world and in our response to the crisis and dealing with the pandemic that had provoked unprecedented healthcare delivery changes. The aim was to focus on early detection, mass screening, early containment of COVID cases and contact. UAE was one of the world's first countries to introduce drive-through screening facilities. So the article will describe the changes in the largest mental health facility in Abu Dhabi, which is Behavioral Science Pavilion, including the remodeling of services, changes in admission rate, outpatient clinic, and emergency room visits. So to give you some hint about Behavioral Science Pavilion, it's the largest mental health facility in Abu Dhabi, and it's the only admitting facility in the Emirates of Abu Dhabi that hosts around 3 million population with only 125 bed capacity. So private sector here in Abu Dhabi only give or provide outpatient services. Usually in normal days, BSB would have around 30,000 outpatient visits in addition to 900 admissions every year. In addition to that, it conducts more than 3,500 annual home care visits. It also offers bedside liaison consultation to 4 tertiary governmental hospitals of Sahha with a total of 1,800 beds capacity in the city of Abu Dhabi. So let's go briefly through the changes. First, in the outpatient clinic department, there were introduction of basic sanitization, social distancing guidelines were implemented, along with flu-like symptoms screening at all clinic entrances. The introduction of telemedicine was the first step after its widespread adoption in mental health facilities worldwide in response to WHO recommendation. Conducting assessment face-to-face was only restricted to newly referred patients or if clinically indicated. So we've noticed in the first 2 months of COVID, there was a drop of 20 to 30% in the total number of clinic visits early in pandemic. The decline was more significant in old age psychiatry population, substance misuse patient, and child and adolescent psychiatry clinic. Regarding the new appointment and the new referrals, there were a 80% drop in a new appointment visit compared to pre-COVID time, followed by a steady rise in the new appointment visit after April 2020. Tele-assessment visits comprised around 60% of all visits initially, and then the rate gradually dropped to be 10 to 20% of all visits as responding to patient requests who continue to prefer face-to-face assessment. So this will give you a comparison between 2019 and 2020. You would see the total visits. Orange is 2019 and the green one is 2020. And then the new appointment visit in blue 2019, and then in the dotted black for 2020. You would see in April and May there were a marked drop in the new appointment visits. So we were not receiving new referrals, and because we made new referrals to be face-to-face, people would cancel their appointment as a new referral or delay it. Regarding inpatient services, all admissions were screened with the PCR test. Early in pandemic, there were restricted areas created in every inpatient units, like 2-3 rooms were designated for COVID patient. But when the cases started to escalate, the drug and alcohol rehabilitation unit was converted to be the COVID unit for suspected or confirmed cases. So everyone will be admitted to drug and rehabilitation unit. When the results are out, if they're positive, they'll continue their psychiatric treatment there. If they're negative, they'll be moved to the general wards. Integrated teams involve psychiatry, internal medicine, infection control personnel, manage those cases. Patients were discharged or transferred to other hospital unit based on mental health evaluation and COVID-19 status. In addition to that, a shift of all physical visitation to audio, visual, virtual visits. So visits of family were stopped, and they can only reach out to their families by using audio, visual, virtual visits, iPads. ECT treatment was initially put on hold, then reinitiated gradually from June 2020, having a PCR test 48 hours before the treatment. From March to June 2020, overall admission were in BSB in general were 168 patients, out of which 33 only had COVID positive and were treated in the facility itself for having a simultaneous acute mental health condition. I would say with time we continue to have 1 or 2 COVID positive patients every week until July 2021, when we had an outbreak of COVID infection in the longest stay residential wards, when all of them got infected with COVID and some of them were treated in the ICU. So this is again the ER and BSB admission trends. The orange is 2019. The dotted orange is ED visits in 2020. You would see there is a marked drop, even with admission in the black color. In 2019, BSB admission around hundreds, and then it dropped in 2020, which we would explain of people fear of COVID at that time. They considered hospitals to be a source, a contaminated place where they would get infection. In addition to that, Abu Dhabi put itself in curfew with a lot of restriction to enter the city, so less patients were coming to the mental health service. The changes in liaison consultation service, so there were an expansion of mental health service during COVID and added emergence of several quarantine centers, field hospitals. So that would had led to 52 increase in the psychiatry consultation during March and April. To overcome this and to manage these patients efficiently, we use tele-assessment method to manage patient and triage patient to overcome the limited workforce and the geographic distance between various medical facilities. Psychology and social worker, psychosocial services were initially limited to cases at imminent risk at BSB outpatient clinic. I would remember maybe in the first 2 months of pandemic, the psychology department continued with less than 10 patients. The staff were moved to focus into COVID-related support programs, joining community toll-free numbers, or starting a public awareness education service. There was a novel supportive service for all COVID admitted in the medical unit in the general hospitals, where social worker would screen by telephone all admitted patients to this hospital to check their mental well-being, their needs, if they want to talk with their families, if they need any supplies, and the medical doctor will refer patients with severe anxiety to psychology team. In addition to that, there were also a program, psychosocial support to medical health staff by doing in-person or tele-assessment psychosocial sessions. By the end of 2020, there was an apparent increase in clinic visits compared to last year and a drop in tele-assessment rate again. Despite the expectation to improve care access, the question arises regarding patients' view of tele-assessment and its effectiveness in managing psychiatric patients. So till today, we give the option for patients if they want to do tele-assessment, but we obviously notice the preference of patient to come for face-to-face evaluation and not liking tele-assessment except if it's a continue or refill visit. The challenges obviously were staff shortage, staff availability was affected as teams were getting infected. People have contact with people with COVID, so they got quarantined. The shortage was propagated by nurses and physicians covering also other COVID services, leading to a significant increased work burden on all mental health workers. Psychiatry residents were moved to support ED physicians. As I mentioned, psychologists and social workers were moved to do other psychosocial support services for COVID patients in the medical hospital. The global shift to focus to patients diagnosed with COVID-19 brings on the ethical dilemma of whether the needs of patients diagnosed with psychiatric disorders were being overlooked at that time. So this is the summary. So we wanted to present to everybody our experience with such a new pandemic to be a reference if we face similar crisis or pandemic in the future. Because when it's first started, we had to meet every day to come up with solutions, to come up with some changes in the service. But since we went through it already, so we know if we face similar crisis, what do we do in the future? I'm done. We'll open the floor for questions if you have any. No question? So we move to the next one. So the next seminar will be by Professor David Nditi, who is a professor of psychiatry at the University of Nairobi, Kenya, and he's the founder director of Africa Mental Health Research and Training Foundation. He's also the director of World Psychiatric Association Collaborating Center for Research and Training. Let's welcome Dr. David. His lecture is about mental health for all.
Hello. It's a real joy to join. it is possible in low and middle income countries to move towards mental health for all, not just a few, but for all. I don't need to go to my credentials, they have just been mentioned. And I want now to go into introduction. And I would like to share with you a few important points. Number one, as we all know, the treatment gap for mental health in low and middle income countries is on average 85, while in high income countries is about 45%. I mean, there are little variations that we have done studies here in Kenya where we actually found it was as high as 95, actually 97 in certain contexts here within the country, Kenya. Many reasons have been advanced to explain this, mainly relatively poor and inadequate resources for mental health in low and middle income countries. The most important of these is human resources. The reality of the matter is that it may take a long time for low and middle countries to catch up with the high income countries in terms of human resources. The high income countries are busy training their own human resources, and I must say quite often we also take human resources from low and middle income countries. All these problems pose several moral questions. Can low and middle income countries wait until they have adequate human resources? We argue that good mental health is a human right, which cannot be delayed for tomorrow. Therefore, there is need to be innovative in using the resources that we already have to provide services that are affordable, are available, are accessible within the communities, and above all, are appropriate, that is, they are evidence-based. With this in mind, we have done several studies here in Kenya which aim to address this moral question. And we did this by designing community-based mental health services in a rural setting in Kenya using the already available community resources, and therefore sustainable even as our efforts are being made to improve the resources. That is, we will continue training psychiatrists, and I think we are doing very well in Kenya. We will continue training clinical psychologists. We continue doing very many things to improve the resources. But while we are waiting for that time when we will have adequately distributed the human resources, we have to do something with the resources that we already have. We have demonstrated that by involving all community stakeholders, and here the key word is all community stakeholders, in dialogue, respectable dialogue, a dialogue that seeks to identify our problems, what we can do about those problems, taking into account the opinion of everybody who has anything to contribute. If we took that kind of approach, there is potential to significantly reduce the treatment gap. This disparity between low and middle countries and high income countries, as I've already alluded, is also as a result of a few other things. Apart from poor human resources and financial resources, we have unresponsive health systems. We have inadequate supply of many medications, and above all, misconceptions and cultural beliefs surrounding mental health, amongst other possible causes for disparity. When we talk about human resources, I want to be explicitly clear who we are talking about. In Kenya, we are talking about a different system. The most important, critically important, may be difficult for us to appreciate this, is the informal health sector. The informal health sector is composed of traditional healers. It includes faith healers, and it includes community volunteers. These are the people who are at the forefront. Research has demonstrated not just once or not twice, but many times in several countries that the first conduct of people with mental illness are traditional healers who happen to outnumber all formal sector several times. The faith healers, if there is a proper mental home, the families will seek the help of their pastors, their sheikhs, whoever happens to be very important to them. And the community health volunteers, they are there. They have been involved in very many management of very many physical conditions. Even today, tracking down or going down to the levels, to the families to know who is COVID positive or HIV positive, very many other conditions. And there is also tremendous amount of research in very well resolved, very highly rated journals that traditional healers, and I'm talking about traditional, leave alone faith healers, they can be very, very effective as important parts of the mental health team at the community level. Many people, as I've just said, with mental illness consult TH and faith healers as their first line of treatment in most rural communities. Though people use a combination of both traditional healers and faith healers, and this happens all the time. Community health workers, as I've just said, are also the backbone of community-based program, HIV/AIDS, now tuberculosis, nutrition, health education, and to a large extent, COVID-19. Community health workers have successfully provided most essential life-saving interventions, especially those that are the leading cause of child mortality. Community health workers also equip families, and I have heard Professor Vailot talk about the importance of families. With the knowledge, and they equip them with the knowledge and skills to prevent diseases. They promote good nutrition, sanitation, hygiene, and link families to essential services. Then there is a formal sector. The formal health sector mostly offers conventional health services based on the Western allopathic model. In Kenya, this formal sector is divided into several levels. There is a community where community health workers go up to the level of the family. They know members of those families by name. More often than not, they know who went without food last night. They know what is happening in terms of family violence in that family. They know who are the drunkards in the family, including the fathers who do not provide. They know everything about those families. And they have a very important link. In the communities, our health facility, there is a dispensary almost in every community. There are health centers, there are sub-county hospitals, and county referral hospitals, and national teaching hospitals. So the formal sector is very, very, very well structured here in Kenya. The World Health Organization developed the Mental Health Gap Action Program Intervention Guide as guide for innovative utilization of available resources in LMICs in order to accelerate the reduction of mental health treatment gap. So we have the support of the World Health Organization, talking about innovative utilization, and again, my keywords, available resources. The image gap calls for each country to contextualize the guides to other social, cultural, and economic contexts. In several of our studies, and I'm just going to mention one or two, and I'll be through, we have developed a stepwise community engagement and a capacity building model prior to implementation of the image gap in a low and middle income setting. And here is a case study of one of the 7 counties, which I think we are doing extremely well when it comes to mental health. And we have actually demonstrated patterns of concordances in imaging gap screening and the DSM-4, ICD-10 diagnosis by community trained service providers in Kenya. Again, another study which was a pilot cross-sectional study. This model demonstrates that it is feasible to identify and bring together various national and community human resources, formal and informal, including government officials, sitting together with all the other people. These are the people who are policymakers, human rights activists, patients and their families, and other community stakeholders to work in synergy as partners and build community social capital focusing on mental health using the WHO image gap, which is official document here in Kenya. And the treatment gap can be reduced by using the resources that we already have. Take-home message, the treatment gap can be reduced by using the resources that we already have. It is possible, therefore, these are my take-home messages. It is possible to bring together community stakeholders to dialogue on mental health. It is possible to get traditional healers, faith healers, doctors, nurses, everybody to sit together at one table and dialogue about mental health in a very constructive way, seeing how best they can complement each other. It is possible to harness already existing community resources to effectively address mental health issues in the community and promote mental health. It is possible to achieve affordable, available, accessible, and appropriate mental health services using the already existing resources. It is possible to significantly reduce the treatment gap using our available community resources. Let me say this at this point. We have been able to demonstrate the feasibility of reduced treatment gap from 85% to 35% using the resources that we already have. Indeed, it is possible to reach most people with mental illness in the communities, provided we are innovative and in our approaches. The papers that summarize all of these things have been in the abstract that we sent earlier on, and I'll leave it to you to read it for yourself, critique it. Has been written by other people, and therefore I've given you the recommendations that we came up with, our findings. And with that, I want to say to the organizers, thank you very much for giving me this wonderful opportunity to share with you what we have been doing here in Kenya. And we are moving forward. We have many other research programs on the way, some of them being implemented to look at different things, including biomarkers of mental illness, and so that we combine science, new science, with what is happening at the community level. These studies will not be done in health facilities, they will be done at community levels so that the communities can own the research process and they can own findings. Thank you very much once again, and goodbye.
Thank you, Dr. David. Any question for Dr. David? So let's move to the last lecture of this session, Mental Health Integrated Plan by Dr. Nahida Ahmed. Dr. Nahida Ahmed is a consultant psychiatrist in the Ambulatory Healthcare Services in Sahha. She's the chair of Mental Health Behavioral Science Council in Sahha and the clinical lead of Mental Health Task Force in the Department of Health. Please welcome Dr. Nahida.
Assalamu alaikum, everybody. Thank you, Dr. Aisha, for that gracious introduction. Thank you, Dr. Medhat and Dr. Ghanem, for this opportunity. It's wonderful to see you all here. I am here today on behalf of Department of Health, presenting our new model of care. That is an aspiration we all have in Abu Dhabi to implement this reforms in mental health by the year 2025. So it gives me a lot of pleasure to share with you our plan. Give me 1 second. There's a little bit of delay in uploading my slides. So the mental health plan was developed in 2019, and the hope is that by 2025 we would have implemented it in its entirety. And there are several stakeholders when it comes to developing this plan. It is spread across different sectors, and it's beautifully planned to meet the deficits and the gaps in the landscape. So basically what we started is we matched our deficits, we measured what was missing, we did a baseline analysis, and as you can see, some of the results that were highlighted was that there was a lot of underdiagnoses. Now we can see why that could be obvious because of the stigma that mental health has in this part of the community. So several of the mental health disorders were underdiagnosed, or the diagnosis rate was simply far below the benchmarks internationally. The primary care role was very limited, unlike our neighbors in several regional countries. As such, they have had a lot of more integration compared to us. So our family medicine was quite secluded, and the services were provided in silos in most primary and secondary and tertiary centers, not at all in primary. There was limited availability of mental health data. The way the data was collected and processed was not sufficient. Suboptimal quality of care. You could see different variety of care given in different centers, so there was no standardization. One could go to a different center and have a different response to treatment. So there was no standardization, which also again limited how the mental health was perceived by public. There was also a huge shortage in workforce, which continues to exist globally, I presume, but we were far beyond the benchmarks. The other deficits we recognize from a social and educational perspective, of course, were lack of awareness. Our community requires a lot more of education when it comes to mental health aspect, because we all know how many myths and taboos are cultivated regionally. So there were not sufficient programs addressing in terms of awareness campaigns. There was limited public information that was sponsored. The services for support reintegration, like when a person gets better, mental illnesses unfortunately are chronic issues, and we did not have enough resources in the community to help these people dealing with mental illnesses with reintegration into community. So many a times, if one's mentally ill, they become disabled or go on social security without a proper psychosocial lifestyle. There was limited collaboration between stakeholders. As I said before, there were people worked in silos. There was not much communication happening between different entities that watch out for mental health. There was lack of dedicated mental health support in schools and universities. So, the prevention and the education begins at schools and universities, and so does the bad habits and the bad the myths and the misinformation, as well as addiction in these days starts in schools and universities, which is not being addressed, and limited support for at-risk people. So these were some of the baseline analysis, through the baseline analysis, some of the factors that were highlighted. Then what we did was we went ahead and we benchmarked ourselves to different countries. Norway, for example, which is the happiest country in the world, we saw what they did better. We took all their examples from Canada with their community integration, having secondary health limited to the community, available in primary centers. Our neighbors from Saudi Arabia actually have a beautiful and expansive plan for developing mental health over the next few years. Bahrain has the highest mental health capacity. So we studied our neighbors and our people across the globe and saw what they did better, and we tried to tailor it to ourselves. And our plan, our project is based on DOH's core values. So if they've been listed here, like patient-centric, so the patient's journey does not begin just when the person comes into the clinic, but the patient's journey begins with prevention. So like we've all studied from different models of care for chronic illnesses, diabetes and hypertension were once killer diseases, but now they're preventable and they are maintained very well. So similarly, depression and anxiety do not have to be so advanced and contribute such a great deal to the the disability and the loss of lifestyle. So the way we have created and developed our plan is towards from the prevention to the treatment and the reintegration. So it's very patient-centric, very collaborative. So it networks psychiatry you would see in the mainstream. It wouldn't be more confined or siloed anymore. Person going to an oncology clinic would have a psychiatry support. Person going to a chronic disease illness would have psychiatry screening. Person re-entering the ER with a traumatic experience would have psychiatric screening. So we have integrated psychiatry as a mainstream because we know down the road when these issues, the mental health issues, are not addressed, they could have really adverse consequences. Community-based, as I said, it's something that is at core of our model. It's very quality-driven, so we have standardizing care. We are making sure that the screening happens using the same tools across all the centers. There is a standard which is maintained when it comes to which is going to be measured through KPIs and different indicators. It's value-driven, so we also want to make it cost-effective. Mental health, unfortunately, in this part of the world is quite expensive and out of reach for many of us. So there is a lot of efforts being deployed in making it more cost-effective and accessible. And it's more forward-looking and innovative, and this is the part which makes me more excited because we have been looking into several startups and different digital platforms that can be incorporated into mental health, and they're doing some really cutting-edge work out there. We recently saw a new program that measures dementia and quantifies dementia as in a very early stage using AI technology. So I'm really thrilled that our model is not just limited to making sure the deficits are matched, but also in terms of bringing mental health to the futuristic platform. So this is our plan. Basically, as I mentioned, we have three major themes, which is staying healthy, getting better, and sustaining health. So under the staying healthy, we have broader themes of like prevention programs. We are going to be screening people going to their PCP's office for various reasons will be screened for depression, anxiety, dementia, substance abuse. There will be early detection would trigger early referral, early interventions, and inshallah early engagement and treatment, which would probably bring down the adverse effects that would otherwise normally have. There are lots of target prevention programs, again by education. We are incorporating a lot of resources into providing education at university and school levels. Through Abu Dhabi Public Health, we've done a lot of campaigns in that regard. In terms of getting better, there is standardization of care delivery. As I mentioned, there will be new standards delivered which will match based on international guidelines, and it's going to make sure we'll try as much as we can to ensure that if a person, no matter which entity, be private or public sector, gets the same standard of treatment. The infrastructure capacity, there was a huge capacity master plan that was published. It's available freely on the Department of Health's website. And we did mention in that there is a severe scarcity when it comes to psychiatrists, psychologists, and social workers, and we're trying to meet that gap. The quality of care would be something, like I mentioned before, something that we have put on at the forefront in terms of like standardizing the quality and having high-level treatment made available. Treatment access and coverage, again, we are in talks with the insurance companies, creating new plans and in favor of expansion of insurance for everybody. Mental health should not be something that is considered as a luxury, but it is a basic need, and everybody would be able to access mental health at one point, inshallah, soon. Workforce demand, again, we will never have enough psychiatrists and psychologists, so we are trying to meet that gaps through integration. We are doing a lot of upskilling programs for our primary care providers. We SEHA was this key partner in this, and we have over the last year trained 23 primary care physicians from across the Emirates of Abu Dhabi, from as far as Al Dhafra region to the middle regions and inland. So we have strategically located, upskilled primary care physicians who would be able to take care of mild to moderate cases and do the easy refills, so that the secondary care is made free for more advanced cases. When it comes to social reintegration, we have partnered up with the Department of Community Health. We've done a lot of, and we're developing a lot of resources. We want to match our Western country, counterparts, where they have stupendous resources when it comes to reintegration. For example, halfway houses, group homes, assisted livings, etc. So these are all in the plan, and it's in the state of evolution. It's developing, and these are our stakeholders, the key stakeholders, besides Department of Health, who owns the project and oversees all of the initiatives. Abu Dhabi Public Health has a huge role to play. They are at the forefront of campaigns and prevention. ADEC is taking up the education part of it, not just education of community and people in universities, but also developing programs. We are expanding master's programs for psychology graduates in different universities. We are rallying for more upskilling programs, so that way we'll have more workforce developed locally for us to recruit. The DCD, Department of Community Development, has done an incredible job. They have started with a crisis helpline. SEHA is, again, very privileged to be a partner with them. They're working on a halfway house, and there's a lot of social resources that are being developed and will be incorporated. ECA, again, is going to early childhood agency, would be helping us with a lot of social problems that people, women and children come across. So this is one of the slides that I'm really passionate about, and something that we take pride in, which is integration of psychiatry and primary health. The picture on the right describes the journey of a person through primary care system. So as you can see, anybody coming into a primary care is, for any illness or any type of presenting complaint, would be asked to screen themselves for depression, anxiety, and based on their red flags, which we have listed in the standards, they will be screened for different diseases, such as eating disorder or substance abuse, dementia, based on the age group and the presentation. So the screening tools have been standardized, and we've adapted the tools that that have been validated worldwide and used most frequently. And the screening and the referral pathways are going to be set up. If it's mild to moderate, they go to their primary care provider. Primary care provider, implements early intervention. If it's a little bit more advanced, or the primary care provider thinks that they're not at ease addressing this, they are referred to a secondary provider, which is a psychiatrist, co-located or in a secondary center. And then finally, they are reintegrated back into the primary care. So the journey is completely holistic. Nobody falls through the cracks. There is no negligence in terms of addressing their medical and mental health issues. So it's a complete, all-rounded service. So this is our aim, inshallah. As I said, by 2025, we hope to improve quality, lower the cost, and enhance socioeconomic conditions. This brings me to the end of my slides. Thank you for your attention.
I'm the Vice President of World Association of Psychosocial Rehabilitation. And I'm the Director of CNK Hospital Private Limited, Kerala. And I'm also the General Secretary of WAPR India Foundation. My presentation today is about the COVID-19 and psychosocial rehabilitation in India. As has created a havoc in the whole world, especially in a country like India, vast country with this much of population. Everything was in a standstill, how to proceed and what to do. And we didn't have a clear idea about how the virus goes and spreads and what is the track record of this. And as we don't have any information earlier, we were not in a position to take a decision at that time. And the spread was increasing like anything. Then the first thing came was the lockdown. The lockdown, that created a lot of problem in the whole country. And the first time, people like us in our lifetime, first time we are in, just going through a lockdown. In the border states of India, they had they have faced with some lockdown during the war season. But in southern side, nobody knows what is lockdown in itself. And so wherever a positive case was found, and that area was declared as containment zone. And all the traffic and the movement to that area was closed. Then that's for a fixed period. And people were not allowed to get in or not allowed to go out. And the total supply was provided by the government and the voluntary agencies. So as the people was not obeying the rules at that time, then the Pandemic Act came into force. So to wearing masks as well as keeping social distances and not attending public programs, and especially in religious places and functions, marriages. So the Pandemic Act was enforced. And that created another problem, that there are a lot of lockdown violation cases were reported. And some in Tamil Nadu state itself, the FIR filed was 1,84,748. And 1.56 lakhs vehicles were seized. Then a special honors were given to doctors and health staff, because health staff, by facing all this risk, they were taking over duties, and some places 24 hours continuous duties, and most of them were wearing this PPE kit for a long time, and their involvement is very high, because suddenly the lack of space and the lack of beds, everything was a big problem, and there was no proper care for the suffered people. So almost all hospitals, sorry, most of the hospitals were converted as COVID centers with a 24-hour service. Then hospitals, there are separate, as per the Pandemic Act, a separate fever clinic was established. And that is with a separate entrance. So those who are coming with a history of fever, they were separately monitored, and they were admitted in a separate ward without having any communication with the other hospital people. And this separate staff were employed in those places to conduct this, to examine these people, and separate doctors were there and nurses were there. And some of these fever patients during observation, they tend to be COVID positive. And then they were shifted to the COVID centers. The identification of the positive cases and the route map was made. So whenever a person was identified COVID positive, and people will first, and the authorities will first found out where he has traveled last a few days, and found that how many programs he attended and how many houses he visited, and identify these people and kept them in quarantine. So that quarantine decided after according to this route map. Then quarantine centers were formed in panchayat level, that means village level, then taluk level and district level and medical college level. Those positive cases without any serious symptoms, only some throat pain and fever only, they were admitted in panchayat level, and there some of the schools and some of the public places was transferred to COVID centers. And there doctors and nurses were there, and if anybody is developing any more symptoms, they will be referred to taluk level COVID centers or taluk hospitals. Then those another category, if the patient again develops severe chest infections or breathing difficulty and oxygen saturations coming below 90 or 84, like that, they were shifted to district hospital level. And there also separate COVID ward was established for that, and it was well equipped with more staff and oxygen and all these things. And those who are not able to manage there and having severe symptoms from there, they were transferred to medical colleges. And medical college was the tertiary care center. And one case at 94 years old, one patient was totally recovered from the COVID positive symptoms and complications from the medical college. That is one among the cases first reported in India. Then creating awareness and education for the public, and the public places were kept on placards, and separate meetings were conducted for the to make the people aware about their the importance of the spread and how the airborne spread occurs, and what is the meaning of the social distancing, and what is the importance of the hand wash and sanitizing methods. This hand wash, how you have to observe this hand wash, and these things were given proper education, and separate soap and water were kept in the entrance of the most of the institutions and the government offices, and also sanitizing materials was also distributed there. Then COVID-19 as a public health emergency suddenly turned to a pandemic, which is declared by World Health Organization January 30th, 2020. Then the media, the social media as well as the print media has taken a different turn, and they were given a very astonishing news about killer virus, and that creates panic again among the public, and perceptions of a danger and confusion, and the total the running of the state was in a difficult situation, and the society's attitude was very, very different, and there's a total rejection in the first phase, and those who was identified with the positive case, corona positive, they were totally isolated from the community, and people not allowing them to go out of the place, out of the house, and they were not contacting them also. And this created a lot of social issues and human rights violations. The lockdown again creates another problem, that the closure of all factories and suspended public transport, trains, flights, buses stopped. Everything was in a standstill. And due to these problems, people started walking through distant places, especially from Maharashtra and all. The sudden spread of COVID, and almost all the slums were totally infected by coronavirus, and the migrated laborers were walking through distance like 70 to 80 kilometers, and there's a lot of problems in that regard also, because everything was declared suddenly. Then in lockdown, that created another problem, is that it cut ties to all sides and search possibilities to create new ties. And people develop new hobbies and new engagements. And this created a lot of problems in that regard also, because everything was declared suddenly. Then in lockdown, that created another problem, is that it cut ties to all sides and search possibilities to create new ties. And people develop new hobbies and new engagements. This was a total transformation of the total lifestyle of the people of the villages and towns and cities like that. This lockdown turned everything upside down. Isolation, then loneliness, then a valueless feeling. And some of the COVID centers reported suicide attempt by the people, and there are so many successful cases of suicide, and that created a sudden awoke to think about the mental health perspectives of COVID-19. Then the person developed intense anxiety and uncertainty about what is tomorrow and what is going to happen. And people reported that the death toll has increased like anything. And especially India is a very thickly populated place, and most of the towns and cities are thickly populated, and the villages also are in the same manner. And health screening facilities are less in some of the places. Even though in cities where a lot of facilities and hospitals available in the cities, there also the problem came. The hospital was not able to accommodate the patients who need oxygen, and he needed a special care. And in between that, there's a problem of lack of oxygen supply, which the government has managed that within a few days. And the oxygen was imported from United States and some other friendly countries. And like that, that created a lot of panic among the public. And you could have seen during that time, you can see in social media as well as in TV, that the people are carrying oxygen cylinders in their hands. Then how these rehabilitation centers are affected during this period? Because most of the rehabilitation centers, the problem is that our psychiatric patients, especially those with the chronic schizophrenia and all, they presumably have a cognitive deficits as the part of their illness itself. So they are not able to contain the details or the risk of contacts, as well as keeping a social distance and all these things. And that creates a fear among the doctors also. And the number of visits by the physicians and psychiatrists has reduced. Some places for 6 months there were no visit at all. And during this time, some of the rehabilitation days, the COVID positive cases has increased more than 60%. And there the government has taken a sudden decision that they turned such centers as COVID centers. They declared that centers as COVID centers, because transferring these psychiatric patients from here to some other centers was found to be difficult. So due to that, they declared these centers as the COVID care centers, and the staffs were deputed to that place. Proper staffing was there, and proper food and accommodation and medicines were given properly there. And that has really was a very, very important moment in the COVID space, because that was able to prevent a havoc in this area. That was able to prevent a number of deaths of patients in these institutions. And the timely and arrangement of these things saved a lot of lives. Then the infection among staff increased 6 months period. PP kits and suspected cases. And a lot of deaths were reported among the people who is managing the healthcare system. And especially in psychiatric wards also, the number of people coming for duty, that also changed, and they were also getting infected. And that created a confusion among the authorities also how to proceed. Then as the physicians and psychiatrists were not able to visit these places, the teleconsultation started at this venture. So video calls, and started seeing patients through video calls, and some other places with computer facilities, they were having teleconsultation through this manner. And that solved a lot of problem, and we were able to give proper medications and arrange the dose, rearrange the dosages, etc. And even though the physical examination was not possible at that time, But the nurses on duty, they used to give a clear information about the patient's current status and vitals, etc. Then consulting room arrangements was also changed. Then the strictly observing these precaution methods, and everybody used to wear COVID-19 masks and for the quality, special quality, and also shield, apron, and screen. There's a screen was fixed, a transparent screen was fixed on the consulting table, and so that the direct spread as well as that will prevent from the airborne infections. Social distancing was a rearrangement in the ward, because the ward, some places the distance between the two beds were only 2.5 to 3 feet. There the ward arrangements are staged, and dining hall also, and the 6 people used to sit in a table that made to 4 people. Then recreation area also, the people who is watching TV and other things, there also the social distancing was well maintained. And the places where 50 to 60 patients were accommodated, that converted into 2 to 3 batches. And like that, they were sent to recreation hall as well as dining hall. And at a time, there won't be more than 15 to 20 people at that time. That helped a lot in the further spread of COVID in this rehabilitation centers. Then the problem came, the limitation of space to accommodate these people and keeping this type of distances, social distancing. There, some of the few patients were shifted from these places to in some other quarantine centers. That was also well organized by the public health authorities in the state as well as the center. And ambulance service was well maintained, and there was district level consulting station, and there was the SOS instruction was given from there. And that center was functioning for 24 hours, and they were directing and they were controlling the ambulance service as well as admission in COVID centers. Whenever a positive case was reported in any places, that we had to register that in our site, and from there, and that's a common site, from there they will take the informations and they will direct the village authorities and panchayat authorities regarding the information, and they will go to the patient's house and found him and get him admitted in the COVID centers through this ambulance. These ambulances were managed by trained staff with all the precautions. All the COVID precautions and protocol were maintained in those things. And social distancing were kept like this, and the OP and all these places, the separate markings were kept, and the people were allowed to stand on that only. The sanitation process, frequent hand washing, as I told earlier, soap solution provided in different places, near entrance, reception and dining hall, and wards also. Then the problem comes about the financial burden, because almost all these rehabilitation centers were running in the financial difficulties, and they have difficult problems during those days. As you know, the finance were not sufficient in all, not in public sector as well as in private sector. And in most of the countries, as we know, that only below 1% of the total budget was spent for mental health activities and functioning. And the same with the rehabilitation centers also, and the staff burden. And the staff are overworked, and they were not able to contain the workload during those days, but most of them were very cooperative and dedicated. And the death rate among them was also very high. That's why India, they have conducted some special programs to honor the health workers as well as the people who is working in health sector. Then this, as Dr. Gabriela mentioned in the bulletin, our president-elect, he mentioned that the confrontation between man and nature, the disease becomes stronger than us. That was his message in our last bulletin. That's a very correct statement. It was a real war between the nature and the men, but the nature succeeded and the men failed. The disease becomes stronger than us. That is the main thing. The Indian philosophy, the concept of Indian thinking is like that. Nature, they are considering nature as God. So during the lockdown, another thing was that there's no entry for outsiders, staff non-cooperative. Because of this workload, some of the staff become non-cooperative, and there are separate sessions were conducted for them to make them aware of, or make them aware of the importance of their duties and what they are doing for the community. Going out of the center, 1 to 2 weeks of quarantine, and that is also another problem. And most of them are staying in their families, and that creates a problem in their families. During the first phase of the illness, there's no home quarantine was allowed here, and after a few months only home quarantine was allowed. And that was another success in this regard. Then staff training was the most important thing, patient training as well as staff training. The staff was trained to conduct training for the patients. Then the classes handled by experts and details about the nature of spread and the what is coronavirus itself and the longevity of the virus, because this is a new topic. So people who are well experienced in that aspect, and doctors, psychiatrists, as well as microbiologists, they used to conduct these classes. Then staff training program, very few number of people were taken to the class, and all this COVID protocol was maintained in this during that time, and classes were conducted, so 1 hour sessions, and all their doubts were cleared during these classes, and that found to be very effective. And they used to conduct classes for the public as well as for the patients. This is also another place where classes were conducted. These classes, not only for the health workers, this public also started attending these classes. This is classes for the patients also. Then infectivity of the virus was the main topic in these classes. Then preventive measures, mask, social distancing, hand wash, and sanitizing method. Even though the main success of these classes were the staff were able to convince our patients who is the cases of even chronic schizophrenia, they were able to maintain the social distancing as well as this wearing of mask after repeated prompting, as well as the training in that aspect. That's a part of the rehabilitation also. That's even though the people are having some cognitive impairments, they were able to train in these aspects. Then educating the residents, staff, doctors, and social workers, and public health experts. They used to train the behavioral therapeutic techniques in training the patients, especially in schizophrenic patients, that they took a few hours to few days to get them trained into that aspect. Then the hurdles, the symptom complex of the residents, especially psychiatric symptoms, and difficulty in understanding and the cognitive disability. Those things, that were the main hurdles we faced in the initial days. But we were able to manage that with the proper counseling as well as the behavioral therapeutic method of making them understand about the importance of wearing masks, etc. So there's a lot of complaints about the mask. When they wear masks, they have breathlessness. So they were afraid to wear masks. But it was very well cleared, and it was shown through pulse oximeter that their oxygen saturation is not reduced by wearing masks. Then in the initial phase, we had a difficulty in convincing them regarding that. And like that, the stigma of mental health is in the one aspect. And that was there in almost every places in the world. The stigma is there, but we were able to reduce the stigma. But the COVID itself became another stigma. There's a double stigma was here. Then these things were cleared with personal counseling and personal consultation. And then found that most of the places, the rehabilitation centers, had a very healthy outcome and the death rate was comparatively less in these places. Even though in the initial days some high rates were reported in some places, but subsequently death rate has decreased, and the admission was clearly based on the COVID protocol, and the relative visits was also very restricted, and that was also observing in the COVID protocol meaning in that one. Thank you very much for the patient listening, and these are the things which we faced in India during this period. And I thank the organizers for giving me an occasion to present this fabulous conference with a topic like this. And once again, I congratulate the organizers and especially the organizing committee chairman, Dr. Madat, for conducting this conference in such a big way in this COVID period with a lot of restrictions and limitations. Once again, I congratulating the organizing team. Thank you very much.
Assalamu alaikum. Thank you very much for your kind attendance for the Congress, and really we're appreciating your presence and interaction with us. Now I'm going to introduce my dear daughter and dear colleague who we worked together for some time, and now she's going to present the next presentation. Dr. Ala Al-Naqbi is a specialist psychiatrist in Sheikh Khalifa Medical City, and she is now responsible for psychiatric rehabilitation unit in Sheikh Khalifa Medical City. And together with Dr. Aisha, they are setting a new limits for promoting the community psychiatry and the daycare services. So please join me welcoming Dr. Ala.
Good afternoon, ladies and gentlemen. It's my pleasure to present one of my favorite topics in psychiatry, which is the mental health crisis intervention and support for patients. My name is Dr. Ala Al-Naqbi. So the objective for this lecture to present the mental health crisis and to differentiate between the mental health crisis and the emergency, and to describe the types, phases, and balancing factor of the mental health crisis as well, and to recognize the signs, symptoms, and contributing factor of a mental health crisis. Also, we'll talk about summarize the goals and the methods involved in the mental health crisis intervention process, and we will explain the consideration involved in the mental health triage as well. We will discuss the steps involved in the mental health emergency management, and we will identify the ethical and legal concern related to the care of the patient experiencing a mental health crisis or emergency. So as an introduction, everyone experiences a personal crisis. Crises are acute, time-limited, experienced as overwhelming emotional reaction to one perceptions or an event. A crisis can be defined as an unstable situation with uncertain outcome in which the individual's coping capacity is temporarily overwhelmed. Such crisis may be generated by external event, intrinsic process, or combination for both. And the crisis for one person may not be for the other, and what's now crisis may not be the same for the future as well, especially with the different setting. Most often, clinicians encounter as an individual in crisis in emergency department and on the crisis hotline. However, this individual may also encounter in the community as well, in inpatient unit, rehabilitation facilities, outpatient clinic, nursing home, and assisting living facilities and the home health setting as well. And it's important to recognize the addressing problem before physical safety became an issue as an important step in the successful management of the patient experiences a mental health crisis before it became a mental health emergency as well, which can be a life-threatening. So what's the mental health crisis? They define it as a non-life-threatening situation in which the people may experience intensive behavior, emotional, or psychiatric response to trigger by the perceiving event, and those who have a behavioral put them at the risk of hurting themselves or other, or prevent themselves for being able to care for themselves as well, or functioning in effective in the community. The type of the crisis they categorize as maturational, situational, adventitious, and crisis of the social culture as well. So for the first type, its development, a crisis may occur in the transitions period and the normal process of biopsychosocial growth development. And it can be successful stage of the life required cognitive and behavioral change, and the crisis can develop at any stage of transition when the person is unable to envisage being in a new role, lack or adequate resources as well, or if there is any impairment in the communication skills or other social system which refuse to see the patient in a different role, life stage and related concern. This is like, for example, during the childhood, during the beginning of the school, during the trying to establishing the peer relationship, during the peer competitions, during the adolescence, during the puberty as well, during the period of choosing a career, living home, choosing or getting married, managing a home, being pregnant, during the childbirth, the middle of the adulthood, in situation of the retirement and reduce the income, and the situation of the death of the partner or death of the close friend as well. Situational crises often revolve around the grief or loss, usually the loss of the established support or role. This arises suddenly and unexpectedly from the external resource and the event or circumstances, like threaten physical, social, psychological, integrate, or individual. This event may originate in the physical body as a result of disease, injury, or social or emotional situation, such as during the unexpected job loss, during the change of the financial state, if there is any academic failure, divorce, mental illness, birth of a child with disability, if there is any serious injury, death of the child, loss of the partner, diagnosis of chronic or terminal illness as well. The third type, which is the adventitious crisis, they have been called the event of the disaster. They are rare, unexpected happen that are not a part of everybody's life, which may result. Like, for example, the result from the nature disaster, such as floods, fires, earthquake, global pandemic, influenza, and like what happened during the COVID-19, during the national disasters such as airplane crashes, and during the interpersonal disasters such as assault or rape, and during the act of terrorism. Because of the severity of the effect of such event, normal coping strategies may not be affected, and the support system may not be available because of the mental health professionals must respond quickly to the large numbers of the patients at the time, including the entire community as well. The third part, which is the socio-cultural crisis, occur when the individual or member of a community function in conformity with the interest, values, and the social structure of the community. This may involve the discrepancy practice based on the age, race, sex, sexual preference, or class as well. How can we recognize a mental health crisis? There is some event that shows that this person is experiencing a mental health crisis, like being in a rapid mood swings, especially with the depressed patient, withdrawal patient, or the patient who's keep talking about the suicide. And if we note the patient having increased agitation, like being more irritable, excessive talking, and if we found that this patient failed to perform his daily hygiene task, and if there is any anger outburst, and if this patient is keep talking about making verbal threat as well. Also, if this patient keep showing some paranoid thinking, verbally talking about it or noted by the family or the around people, and if there is any abusive behavior to the self or other, like if there is any substance use of the self-harm as well. And if we notice this patient is withdrawal or isolating himself from the school, work, family, and friend. So when individuals in a crisis found to be immediately threatening harm to self or other, the crisis has become a life-threatening situation and the mental health emergency exists. Evidence that the person is experiencing a mental health emergency, like if the patient acting on the suicidal threat, he's acting on his suicidal thought. If there is severe disorientation, and if there is evidence of psychosis, like losing of a track of reality, inability to recognize the family or the friend or understand what others are saying, and if there is any homicidal or threatening behavior, if there is self-harm required immediate medical attention, if there is a severe impairment by the drugs or alcohol, if there is a high erratic or unusual behavior, which may affect the safety care as well. And if there is being aware of various risk factors, may alert clinician to patient facing a potential mental health crisis. So the factor that can increase the risk for the mental health crisis, like if there is a family history of mental health problem, if there is present of the history of the mental illness, if there is any abuse or traumatic event in the past, if the patient being bullied or bullying other, if he has a poor academic achievement, if there is a presence of concurrent illness or injury, if there is use of alcohol or substance, if there is a poor nutritionist, chronic pain, lack of the sleep, if there is any other stressful life event he went through it, if there is any low self-esteem, negative self-perceptions, if there is lack of emotional awareness, if he believes it's outside the lack of the control, if there is a lack of social support, and if he lives in a poverty as well. So the goals of the mental health crisis management are to ensure the physical safety and emotional stability of the person who experiences a mental health crisis, and to reduce the intensity of the emotional, mental, physical, and behavioral reaction to the crisis, in order to avoid a further deterioration of the patient's or the person's mental state, and to develop a serious long-term problem. Also, the goals to assess and recovery from the crisis and the return to persist the level of the function as well, and to assess the developmental of enhanced of more effective coping skills and support system, and to provide, of course, the assistance and referred for the ongoing care. When we talk about the crisis process or the crisis triage, usually the aim for the triage is to determine that it's likely the person has a mental health problem and what the nature of his problem, and to establish priority for the response based on the immediate safe issue, and to incur about the concerned social or health problems that require attention, and to determine what intervention is the best suit for the person, and who the person should be referred to. Triage is usually followed by comprehensive assessment once immediate issues of the safety has been addressed. So mental health emergency behavioral management usually started with de-escalate, which is usually the first step. When a person is unable to control emotional or behavior, the following de-escalation technique have been found to be frequent and successful in less than 5 minutes. remove from the stimulus, respect the person's space, set a clear limit and expectation until the patient that the injury to self and other will not be tolerated. And establish a verbal contact if possible, and the first person to contact the patient should be the staff leader. Otherwise, design one or limited staff member to interact with the patients, introduce self and staff, and orient the patient to emergency department or facilities and who's the expect. Reassure the patient that they will be a help, recognize the person in the midst of the mental health crisis emergency may be unable to clearly communicate thoughts, feels, or emotion, and use the consensus of the symbol language and repeating the message and allowing adequate time for the patient to respond, which can be helpful. It's also important to use the active listening skills, identify the feeling and desire, listen attentively and empathize with the person's feeling, and agree or disagree, or using a faking empathic technique in which the one found something about the patient's position. Collaborate, use a collaborative approach with the goals of helping the patient to calm themselves. The second step, which is the restraint and seclusion, initial management should include use of the escalation technique, but when the people in crisis became a distress that they are dangerous to themselves or other, it's may necessary to place them under restraint or isolate themselves. Seclusion is the involuntary confinement of the patient alone in a room area, which the patient is prevented physically from leaving. It may be useful for management of violent patient distractible behavior. And restraint is a manual method, physical or machines, device, material, equipment, or use of medication against the person's will that immobilize the patient or reduce their ability to move arm, leg, body, or head freely. Restraint may only be used to ensure immediate physical safety of the patient, a staff member, or other in the vicinity, and they must be removed as soon as possible as the patient and person in the safe area or safe situation as well. The third step, which is the sedation with the medication, referred like a chemical restraint defined as medication, drugs, or combination method for managing the person behavior, restricting the person's freedom of movement or impairment the patient's ability to appropriate interact with their surrounding as well. Chemical restraint, however, is now considered as a historical concept, and it's not standard treatment for the patient's underlying condition. Today, there is understanding that the medication are insist used to treat the condition, agitation, and underlying causes, not for restraint. Sedation with the medication may be necessary with or without physical restraint, and rapid tranquilizations may be required in the agitated or violent patient who does not respond to verbal de-escalate technique. Rapid may be required for the severity or severe agitated or violent patient. A drug often used for sedation include the benzodiazepam, antipsychotic, dissociative anesthetic. However, currently there are no drugs in the US are FDA approved for chemical restraint. And the debrief, the patient and the staff in involuntary intervention indicate debriefing may help restore the working relationship with the patient and help staff plan for possible future intervention. The briefing should involve the explanation and why the intervention was necessary, and the patient should be asked to explain their perspective of the event. Options or alternative strategies may be discussed within the patient and the staff should the situation arise again. Now we will move to the ethical and legal issue. So the ethical principle, severe of general guide for behavior. As we know, there is a 4 common accepted principle for the healthcare ethics, like the respect for the autonomy, non-maleficence, beneficence, and justice. And usually in the crisis intervention, we always remind ourselves about this ethics. And when we reach or when we revise the goals for the crisis interventions, it's to prevent any harm to the patient and to assure the patient in safe situation, safe condition. So we need to during the process of the crisis intervention, we need to remind ourselves about the four principles of the health ethics, and we need to explain to the patient what we did. It's for his benefit and his priority as well. And this is my reference. Thank you very much.
Okay, any questions? Any question? I think we had a very good presentation and the reason now, and we were able to get a clear idea about how they manage the things there in UAE. Any questions? Did you receive any questions? Or any clarification? I think as there is no question, no any comments?
Thank you very much, Professor Radha Krishnan. It was very good presentation, and thank you for all your support and being live with us from India. I hope everything will be fine with you, and we'll meet physically soon. Thank you very much, and with this we conclude that session. Thank you very much, sir.
Thank you.
So now the time is to introduce our guest speaker, guest of honor of the Congress, Professor Abdul Javid. Professor Abdul Javid is the president of the World Psychiatric Association. Dr. Abdul used to be one of the best in leading different associations. He led WAPR for 3 years, and it was very fruitful 3 years. We had so many new branches open during his presidency, and also he was the chair of the president of the Asian Federation of Psychiatrists, and we made one very successful congress for the Asian Federation of Psychiatrists here in 2016. Professor Abdul is honoring us by giving a talk today. So please join me welcoming Professor Abdul Javid.
Live now.
Should I start?
Yes, please.
Sorry. Am I audible? Should I start?
Yes, doctor.
Bismillah ar-Rahman ar-Rahim. Dr. Medhat, Professor Murali, respected officers of WAPR and WAPR UAE branch. Let me first congratulate Dr. Medhat and his team for organizing WAPR Congress despite we are having a number of difficulties. I must say Abu Dhabi is a great venue which is not only famous for its hospitality but also very famous for an excellent organization of International Congress. I'm extremely sorry I was unable to attend in person, and this was just because of the current new wave, which is putting a number of travel restrictions. Without wasting any further time, I will be talking during the next 25 to 30 minutes about the challenges that we are facing in psychosocial rehabilitation. I will start first with understanding the mental health. What is psychosocial rehabilitation? Is it important? And what are the current challenges that need to be kept in mind for going forward? When we say what are the global challenges in psychosocial rehabilitation, there are two areas that are important. The first one is the conceptual, that what is psychosocial rehabilitation, what is the philosophy, what is the mission, and then the difficulties in carrying out those conceptual boundaries and putting the concept into practice. But let's start with the most important aspect, even before we go for any treatment or rehabilitation. Is mental health important? And is treatment of mental health a human right? This is a very old slide, which was taken from a paper published in Lancet. But this argues that neuropsychiatric disorders, especially the major mental health problems, constitute a big number of general population. We are not underestimating other disorders like respiratory, cardiovascular, cancer, or GIT, but we want to emphasize that mental health problems are the most common disorders that we see in our practices. But it's a pity that despite 25 to 30% of global population having one or another type of mental illness, more than 2/3 of people are without any treatment. And this is not only the case in low and middle income countries, even in the richest countries, there is no exception. And then when we look at what are the directions for the 21st century in health and social care systems, I always say this is a century of citizenship. And the priorities to become a citizen or to enjoy the citizenship means that our patients also enjoy the human dignity and the quality of life. Some of the aspects of this citizenship could be dignity, respect, independence, human rights, physical well-being. But now the addition of mental well-being is also one of the important pillars on which the citizenship stands. Now, going to the understanding of mental illnesses. Despite we have got 25 to 30% of population that may present with psychosocial or psychological problems, we are still struggling understanding the mental illness. This is a very interesting quote from 1925. And it says, the physician knows madness only in one way. He collects the symptoms, tries to find out causes and cure, but the madman actually knows far better than the clinician. And this is the essence of understanding mental illness, that when we see our patients, we see from our own eyes. And this code very clearly emphasized that we need to look from the patient's eye, patient's carer's eye, and the family's eye, that what are the sufferings of mental illness. I think comparing with the last century, there has been a lot of changes in the context of mental illness. Whether this is the meaning of symptoms, whether this is stigma and self-image, social determinants of mental health, social consequences, behavioral consequences, we do see that mental illnesses and mental health problems are getting a better recognition. So with this understanding, generally speaking, when we talk about treatment in healthcare facilities, we talk about prevention, we talk about interventions and treatment, and the famous quote, prevent if you can, treat if you can, rehabilitate if you can. So rehabilitation is an important milestone in the journey of treatment. And this is particularly true for mentally ill. So what is rehabilitation in psychiatry? This is not a new concept. Actually, management of mental illnesses always influenced by kindness, compassion, and hope of recovery. And this is what constitutes what comes after the acute treatment of illnesses. And the history of psychosocial rehabilitation really got a big momentum at the end of the 20th century to the beginning of 21st century. It is true that the mental illnesses were treated primarily treating the psychopathology and the severity of symptoms during the last century. But now the concept is changing and including many other areas which are very important areas in terms of rehabilitation and reintegration into the community. It could be occupation, it could be housing, it could be stability in relationship, or it could be financial autonomy. So these are the new directions globally taking place in the history and the practice of psychosocial rehabilitation. I just want to share with the definition that has been put forward by WHO. This is a generic definition. And it says that rehabilitation defines as the application of measures aimed at reducing the impact of disabling and handicapping conditions and enabling disabled people to achieve social integration. So two important aspects of this definition. To look at the impacts of disabling and handicapping situations and trying to make it and enable disabled people to achieve social integration. When it comes to the mental illnesses, this definition gives us an exemplary background because mental health problems are linked to all these aspects. So this is how the term psychosocial rehabilitation emerged in the dictionary of rehabilitation. And psychosocial rehabilitation is not only rehabilitation for psychological symptoms, but also about the programs designed to help our patients to overcome disability, impairment, and reinforcing independence. So PSR, or psychosocial rehabilitation, is a treatment approach that is designed to help improve the lives of people with disabilities. It is not only taking care of the symptoms, but also the quality of life. And a step further, the goals of psychosocial rehabilitation are to teach emotional, cognitive, and social skills to help people who are diagnosed with mental health problems. So based on these pillars of hope, empathy, and social integration, the whole structure of psychosocial rehabilitation rests. In the past, we have been using different terms which were determining the way and the processes for rehabilitation in psychiatry. We talked about handicaps, we talked about disabilities, then we moved to impairment models. But over the years, there has been a big change in the concept and in the practice of these previous or past directions. Recovery, for example, has emerged as a model, as an approach, as a movement, and as a paradigm that all mental health policies are now emphasizing the importance of recovery. But what is recovery? Recovery is an integral part of psychosocial rehabilitation and is translated in the current words about the importance not only about the concept, but also about the practice. It focuses and interests on persons and personal meanings and strengths, and emphasizing on personal responsibility. Unfortunately, the term recovery is interpreted differently by patients, differently by clinicians, differently by users, differently by the families. But the overall concept of recovery movement is personal empowerment, raising realistic hopes for a better life, and emphasizing that the goal of recovery may not become normal, because there are some illnesses where we can't get 100% normality. The goal is to embrace the human vocation of becoming more deeply, more humane, and more functional. So the current concept of both rehab and recovery is emerging as the restoration of functions, capabilities, and independence in improving physical and mental health. And when full restoration is not possible, the aims are directed to restore the possible functioning and limiting any further impairment as far as we can go. And in summary, which is probably the best example of describing psychosocial rehabilitation, the clinical recovery means getting better, and personal recovery means living well. I think this is a global challenge that we are facing to accept about the future practices of psychosocial rehabilitation. So, ladies and gentlemen, in summary, psychosocial rehabilitation is not just one of the treatments. It is a holistic approach, but it is person-oriented. It is person-centered. PSR can benefit overall wellness. Many treatments may be limited to treating one part of the illness, but PSR is globally and comprehensively looks after the illnesses. And it is not only the treatment of the symptoms or the residual symptoms, it is also improving the skills for your quality of life and for your working. So why PSR is the need of the hour? Because we have seen that focusing on treating the symptoms is not possible or helpful to our patients when it comes to mental illnesses. So PSR is an effective treatment, an effective part of the treatment that is designed to enhance the mental health and improving the lives of the affected people. I think this is what we need to communicate to our patients, families, carers, and more importantly, to the policymakers, that psychosocial rehabilitation strives to address entire areas of the person's life that contribute to overall mental and physical well-being. And PSR, rather than simply focusing on areas of weakness, PSR focus on empowering clients and building on their existing capabilities. So this is an important step forward in understanding the importance of the psychosocial rehabilitation. And as I have tried to explain, it is not only reintegration into the society. It is not only rehabilitation. It is actually a number of areas that could be linked to the symptoms, to the functioning, to empowerment, independent meanings of the symptoms, and more importantly, personal meanings of cure and outcome. So this is something different from the treatments which we were offering to our patients many decades ago. And going back to the dimension of rehabilitation, we have to be mindful that it limits disability, or at least tries to limit the disability, minimize the handicaps and impairment, promotes a culture of healing and hope, empower people for quality of life, social inclusion, citizenship, and resettlement as independent individuals in the society. And based on these rehabilitation principles, recovery is offering us another dimension, which could be clinical recovery, social recovery, or psychological recovery. I think this is a big challenge globally, that we are not taking all these aspects of recovery in our minds when we are designing the new services, or we are working on different aspects of care and management. Sometimes people ask, what is the difference between rehabilitation and recovery? I always say that these are the two sides of the one coin. Rehabilitation refers to the services and the technologies, and recovery refers to the lived or really life experience of persons as they accept or overcome the challenges of the disability. So we should not talk about rehabilitation versus recovery. We should always talk about rehabilitation and recovery. And it is not only the symptoms, it is not only enhancing the quality of life. There are a number of other dimensions like independence, occupation, physical health care that becomes the most important aspects of an overall package of psychosocial rehabilitation. So, dear friends, what is the way forward? I think we have to promote this concept that when you are talking about managing mental health problems, managing mental health problems includes prevention, treatment, rehabilitation. Because if not all, majority of the mental health problems are chronic, disabling, handicapping, impairment, long terms, and relapsing. So for all these aspects of mental health problems, the solution is not only in prevention, not only in treatment of symptoms, not only in rehabilitation alone, but a combination of all these things. So I would argue that the future directions should be understanding and implementation of rehabilitation principles in a wider aspect. And these are the conceptual changes that we need to work. We must try to shift our roles from authority to coach. This is one of the most important aspects of psychosocial rehabilitation, that we consider patients as partners in deciding the treatments. It is not the professional role to be authoritarian, but it should be to work with the patient. And then working with the risks. You may not be able to finish or stop all the risks. So it should be from risk avoidance to risk taking. That means making the patient understand how he or she can take the risk and avoid any complications. And of course, the core significance of hope and optimism is the future recovery or rehabilitation. And last but not the least, promoting self-management and empowerment. The time has come that patient carers and families are becoming important angles of the treatment triangle. And we need to take them on board rather than being in a directional state. So, dear friends, the future challenge is we should not ask who needs rehabilitation. We should ask who doesn't need rehabilitation. Forget about that, that's only schizophrenics needs rehabilitation. No. People with minor anxiety, stress, trauma problems, they may also need rehabilitation. So if we want to promote rehabilitation psychiatry as a discipline, we have to come forward with new ideas and emphasizing the importance of rehabilitation as a component of the treatment. And we have to include and emphasize this particular challenge in our curriculum for mental health professionals. I always give one example from the medical profession. If we are unable to sensitize our medical students about psychiatry, about importance of psychiatry, we will never be able to convince them about the importance of this particular specialty. And this is equally true for nurses, for psychologists, occupational therapists, and social workers. So our slogan should be, who does not need rehabilitation? And I am so privileged of having my personal association with WAPR for many years. As a past president of WAPR, of course with the support of the current office bearers, who were not only friends, but a source of inspiration for me during my period. We have tried to convince the world that, look, rehabilitation is an important specialty. So dear friends, Dr. Medhat, Professor Murali, Dr. Radhakrishnan, and all others who are joining, once again, congratulations on organizing this World Congress, despite having so many difficulties. I would say organizing of this conference was a part of rehabilitation. Our rehabilitation, our reintegration, and giving us hope and optimism that even professionals can work under difficult situations and difficult environments. Thank you very much, and I hope the Congress will go and have a better impact. And I once again feel very sorry for missing this exceptionally interesting and stimulating Congress, which is a hallmark of Abu Dhabi. Thank you very much.
Thank you. Thank you. Thank you very much, Professor Afdal. Really a very thoughtful presentation from a very thoughtful leader with many hats. Today we are honored with the collaboration between WAPR, WPA, and WHO. And this is the real essence of interaction. And I'm sure that this is the model that we are following your steps through your presidency. And since I knew you for more than 10 years, you're always striving for making more interactions between different organizations. And I hope when you'll be the president of WHO, we'll have more collaboration in the future. I'm looking for any questions to Professor Afdal. I think what you highlighted in the presentation is really unique in the mentioning who actually the question of who doesn't need rehabilitation is very important, and what you mentioned regarding the how we are more interested in personal recovery and the functional recovery of each person, which is the aim of our treatment for all of our clients. So,
Dr. Radhakrishnan wants to ask.
Thank you. Dr. Talat Matar would like to ask you a question, Professor.
Thank you very much, Professor. Thank you very much, Professor Afdal, for the nice presentation. You have mentioned two very important points. The quote you have mentioned that we are the madman, we are collecting just symptoms and diagnose, but he more far than this. The other point you showed to the meaning of the symptoms. Every symptom has a meaning. So do you think, in the light of the modern classification, the current classification and nomenclature of psychiatric disorder, this is promote or inhibit the psychosocial rehabilitation? Now, what we are doing in our nomenclature, just we are collecting symptoms, diagnosing, giving medication. We are ignoring the longitudinal course, the individual, even the axial classification wasn't mentioned. DSM-4 had been removed now. What is your opinion?
Well, I fully agree with you. Classifications are becoming too narrow in terms of only focusing on diagnosis. But now the time has come that we will have to also consider what this diagnosis means, not only to me as a clinician, to someone as a family member, but more importantly to the patient. Once we start understanding even the diagnostic guidelines from that perspective, we will be able to go a bit forward. I'm sorry that you are, and I fully agree what you are saying, and I'm sorry that the current classifications are only focusing on tick box criteria, yes, no, yes, no, yes, no. And we are going away from psychopathology, understanding the symptoms, understanding the meanings of symptoms. I'm sure people will realize this when it comes to the practice. If somebody is suffering from a tuberculosis, a diagnosis is made, that is fine. But we have to really look how tuberculosis is affecting the individual. What does the individual consider that his main problems? You are absolutely right. And I think associations like WAPR should prioritize and focus on these issues of concepts, because concepts will take us to the policy.
The last question from Professor Zeb Tentor, the past president of WAPR, would like to ask a question.
Thank you for an inspiring talk. It is wonderful to think of all of us getting rehabilitation. Inevitably, there is the question of how can we pay for that? And I wonder, with your wide exposure, if you have come across any novel approaches for funding that we could pass on to this audience. In the United States, which doesn't often provide a lot of encouraging news, I'm happy to report that some of our Medicare Advantage plans have started to pay for housing when patients need it. I look forward to your response.
Well, thank you very much, Professor Tentor. You have always been a mentor, especially for me, and I have really learned the ABC of rehabilitation from you. You are absolutely right that how should we convince the policymakers and the health administrators that what do we mean by rehabilitation? And that is why I'm trying to emphasize that we should make it very important that rehabilitation is an integral component of the treatment. While you are talking about intervention, you must and should speak about rehabilitation. In terms of how should we get the funding, I always quote one thing. In psychiatry, there is anti-psychiatry movement. There is no anti-diabetology. There is no anti-cardiology. There is no anti-rheumatology. This is the basis that we have not been able to get our patients and families and carers on board. Policymakers will only listen to us when our patients and carers are with us. I am sure that in the developed world, there are so many other variables. But to answer your question, I will only say rehabilitation becomes a policy decision if we have got patients, carers, and families on our side. This is what is required as the starting point. And then convincing our policymakers how rehabilitation can minimize the overall cost, how rehabilitation can socially integrate. We have recently published a paper in the World Social Psychiatry showing that how financial empowerment of our chronic mentally ill can influence the prognosis and can help our patients to become normal citizens, normal part of the society. I think we have to convince the policymakers through our patients, carers, and also show some of the models of care. And you have been a very great friend of Fountain House Lahore, which was started as a rehabilitation institution. This paper is coming from using an innovative approach about using microfinance in the rehabilitation of mentally ill. I think these are the small models that we should tell people and tell the world that how effectively rehabilitation can change the world, can impose more hopes and optimism.
Thank you very much for the comprehensive answer. Now, the last question is from, this is an entered president's talk. So the question is from President-elect of WAPR, Dr. Gabriel Roca. So please, Dr. Gabriel, your question.
Yes. Good morning, Afzal. Very happy to meet you also in a virtual condition. And only short reflection about your excellent presentation. The principles of psychosocial rehabilitation you presented, I think that are the principle of the approach of the relationship with patients with severe mental disorders. And then I think that with these patients, the difference between psychosocial rehabilitation and treatment is very, very little. Or better, I think that for patients with severe mental disorders, probably psychosocial rehabilitation is, from the beginning, the most important treatment. What do you think about? Thanks.
Well, this is what I was trying to explain, that we should not say who needs rehabilitation, we should say who doesn't need rehabilitation. And it is not only for the chronic or enduring or severe mental illnesses. I'm sure as clinicians, as mental health practitioners, we always find even anxiety and OCD can be very resistive and very complicating and frustrating for the patient. I think that distinction should go, that rehabilitation is only for chronic mental ill. Rehabilitation should be considered a component of treatment, even for those non-severe illnesses, because these non-severe illnesses may actually become severe if not treated appropriately. You are our leader, you are our hope, and being the next president of WAPR, we would believe that you have got the expertise to convince the world about the importance of psychosocial rehabilitation.
Thank you very much for the very comprehensive answers, Professor Afdal, and really appreciate your time. And hopefully we'll see you in person shortly, end of this year in our 2022, inshallah, in Abu Dhabi, in the conference of Abu Dhabi Mental Health Conference, inshallah. I'll ask you a favor just to join me in honoring Dr. Aisha Duferi. She's the medical director of Behavioral Sciences Pavilion, and she's behind all the efforts that we have today. So I just want to give her the trophy in your presence, so in the presence of the presidents of the WAPR. So please, Dr. Aisha. I intended to do that in your presence because I know that you're always supporting all the young generation, and she's one of the promising leaders in the near future, and hopefully we'll do lots of efforts together in WBA and WBR in the future. Thank you very much, and I'm looking forward to see you. Thank you.
Thank you very much.
Now the time is for lunch break, and we'll be back here, inshallah. After the lunch break, we will have some industry-supported symposium by Newbridge. It will be after the lunch break directly. Thank you very much.
Hello, everyone, and thank you very much for the opportunity to be with you today to talk about luresidone, a new treatment option to treat bipolar disorder. My name is Andrea Fagiolini, and I am professor of psychiatry at the University of Siena School of Medicine in Italy. These are my conflicts of interest. So when it comes to treating bipolar disorder, we have to keep in mind that bipolar disorder is often chronic. As you can see here in this study, where a group of patients were followed up for almost 13 years, patients with bipolar disorder spend about half of their life with acute episodes. See, 53% of their weeks without symptoms, but 47% of their weeks with symptoms. And among these weeks with symptoms, you can see that the majority of the time was for time in depression. 32% of the weeks in these 13-year follow-up were spent with depressive symptoms. So bipolar depression is a problem. Treating bipolar disorder is very challenging because we treat a moving target, because psychotic symptoms are very common in patients with bipolar disorder. The difference between bipolar disorder and schizophrenia is not due to the presence or absence of psychotic symptoms. The difference is due primarily to the presence or absence of affective symptoms, which are present in patients with bipolar disorder and which are less present, or at least not to the same extent as bipolar disorder, in patients with schizophrenia. Psychotic symptoms are very prevalent in bipolar disorder. Up to 90% of patients will report experiencing psychotic symptoms at their time in their lifetime, most often during manic or mixed episodes. The course is unfavorable for many patients. Less than 10% of patients are treated with monotherapy during acute mania. 10 to 20% of patients develop rapid cycling. Here you can see in a group of patients with bipolar disorder how many medications they were taking. Only a minority were taking 1 or 2 medications. The majority of patients were taking 3, 4, or even more medications, because this is a disease that is very difficult to treat. In our study, Bipolar Disorder Center for Pennsylvania, a study where I worked as medical director when I was in the United States, what we saw was that of the patients that arrived with symptoms at entry in the study, about 30%, meaning 1 out of 3, did not achieve recovery, not even after 24 months of treatment. This means that after 2 years of treatment, some of our patients, of course, had improved, but some had not improved to the point of meeting criteria for recovery, meaning at least 8 weeks with a CGI of 1 or 2. And of those patients that achieved recovery, in the following 2 years, 40% had a relapse. So bipolar disorder is chronic, bipolar disorder is severe, and bipolar disorder is highly recurrent. And similar results that we found in this one study were found also in the STEP-BD bipolar study still conducted in the United States, where only 58% of patients achieved recovery from an acute episode of depression or mania within 24 months of treatment. So we're dealing with a very difficult illness. And patients with bipolar disorder usually do not present to us in a hypomanic or even in a manic condition. Most often they come to us when they're depressed. And actually depression is one of the main challenges when it comes to treating patients with bipolar disorder. So it's very good to have new medications to treat bipolar disorder. And luresidone is one of the newest medications that has clearly proven efficacy and good tolerability to treat bipolar depression. If you look at the binding profile of luresidone, you see that the highest affinity is for 5-HT7, then D2, then very strong affinity also for 5-HT2A, also good affinity for 5-HT1A, and so on and so forth. Receptors such as 5-HT7 and even more so 5-HT2A, even more so 5-HT1A are linked to efficacy also on depressive symptoms. And also 5-HT1A, where the medication is partial agonist, is good for cognition. And cognition is somewhat impaired during depression. 5-HT2A decreases extrapyramidal symptoms, but also links to releasing some more dopamine in the mesocortical pathway and also linked to antidepressant activity, and in patients with schizophrenia linked to efficacy on negative symptoms. When you look at the Maudsley prescribing guidelines in terms of tolerability, what the medication is to switch patients to when it comes that they have side effects like acute extrapyramidal symptoms, dyslipidemia, impaired glucose tolerance, hypotension, hyperprolactinemia, you see that lurazidone very, very frequently for several side effects is the suggested drug to switch to, because it has low risk of dyslipidemia, of diabetes, of hyperprolactinemia, of hypotension. It's actually the one medication with the lowest risk among antipsychotics for QTc prolongation and arrhythmia, very low risk for weight gain. So not only is lurazidone effective to treat bipolar depression, but it is also a medication that is very well tolerated. The indication of lurazidone are for schizophrenia and for depression in bipolar disorder, either alone or as adjunctive treatment on top of lithium or valproate. The starting dose in bipolar depression is 20 milligrams, and then the target dose goes between 20 and 60 milligrams. The doses in schizophrenia are higher, about twice as much. In starting dose for schizophrenia is 40 milligrams a day, always with food, otherwise it's not absorbed adequately. And then the recommended dose goes from 40 milligrams to 160 in schizophrenia. But in bipolar disorder, the doses are lower, 20 milligrams as a starting dose, and then patients may go to 20, 40, or 60 milligrams a day. In Europe, we use different ways to calibrate the tablets. What you call 20 milligrams, we call 18.5 because we count only active moiety, whereas when in FDA and also from what I understand, I mean in the United States and also in United Arab Emirates, you also account for active moiety plus the salt, but it's basically the same exact thing. In your countries, from what I understand, you have tablets of 20, 40, 80, 120, and the maximum dose is 160 with 2 tablets of 80 milligrams. But in bipolar disorder, the target dose goes between 20 and 60 milligrams. There have been 3 main studies to show efficacy and tolerability of lurazidone in bipolar depression. Of these 3 studies, 2 were adjunctive treatment on top of lithium or valproate. 1 was in monotherapy, and then there was open label long-term extension. Very interesting that these studies, both in monotherapy and adjunctive to lithium or valproate, clearly shown efficacy superiority of lurazidone to placebo in terms of efficacy on a scale measuring depression, like in this case, Montgomery-Åsberg Depression Rating Scale. If you look at the single symptoms, you see that this medication is very strong on symptoms like sadness, like inner tension, like reduced sleep, like inability to feel, like pessimistic thoughts. So it is a medication that is strongly antidepressant. Same exact thing when you look at CGI. CGI-BP means CGI bipolar disorder, and gives an idea of how the clinicians see the patient is doing. And both in monotherapy and in adjunctive treatment, you see efficacy of these medication. Same exact thing in terms of self-report. The QIDS SR is a self-report for depression, and again, you see significant difference with respect to placebo between lurazidone and placebo itself. So you see efficacy also from how patients perceive they are doing. Same exact thing in terms of functioning, Sheehan Disability Scale. In monotherapy study, you see significant improvement in work and school functioning. You see significant improvement in social life. You see significant improvement in family life. In the adjunctive treatment study, meaning lurazidone on top of lithium or valproate, again, significant improvement in social life, in family life, and home responsibilities functioning. So this is a medication that works very well also on functioning, and same exact thing in terms of efficacy on quality of life. So it improves symptoms of depression, it improves functioning, it improves quality of life. In terms of number of responders, how many patients saw a reduction greater than 50% in their score in Montgomery-Åsberg Depression Rating Scale, again, you see strong significance. 30% of patients achieved response in placebo, 51% with lurazidone 74 to 111, that is with your way of calling the tablets 80 to 120, and 53% responded in patients between 20 and 60 milligrams of lurazidone. Same exact thing in lurazidone adjunctive to valproate or lithium, 42% placebo plus valproate or lithium, 57% lurazidone at 20 to 120 milligrams plus lithium or valproate. In terms of tolerability, it's very good. If you look here at percentages of patients that gained or lost more than 7% of their weight, both in monotherapy and in adjunctive therapy, you see that the percentages of patients that gained weight are quite low. In the adjunctive treatment, you see 3.1% of patients that gained more than 7% of their weight, but also 2.8% of patients that lost more than 7% of their weight. Same exact thing, both in monotherapy and adjunctive treatment for cholesterol, for triglycerides. Same exact thing for glucose. Very well tolerated in terms of metabolic side effects. Hyperprolactinemia, relatively low, not like other antipsychotics. There are many other antipsychotics that give much higher degree of hyperprolactinemia. With lurazidone, you usually don't see much of a change in prolactin. Same thing for extrapyramidal side effects with akathisia, Parkinsonism, depending on the study, depending on the dose, may reach 11, 12, 13%. So this is not very low, but not even that high. If a patient develops akathisia, you either decrease the dose or you may add the benzodiazepine, you may add the beta blocker, you may add an anticholinergic, and usually we treat akathisia pretty well. Treatment emergent mania was very rare. So this is an antidepressant that doesn't tend to induce mania. So basically in monotherapy, what they saw was that tolerability was pretty good. The most frequent side effects were akathisia, extrapyramidal symptoms, somnolence, nausea, and vomiting. But still, even if they were the most frequent, they were not that frequent. Like for akathisia, it's about 10%. Very low rate of weight gain, few problems with metabolic parameters, low risk of switch to mania or hypomania. Basically, same results in monotherapy or adjunctive treatment. Before we conclude, after having taken a look at the data about lurazidone in bipolar disorder, wanted to talk about a real-life case. We have been using lurazidone in many patients with bipolar depression. Again, our impression is that it's a very good medication. It improves cognition, it improves mood, it doesn't tend to give mania, it doesn't tend to give side effects such as sedation, such as lots of extrapyramidal side effects, doesn't tend to give weight gain. So it's very good medication for patients with bipolar disorder. Here's a patient, 30-year-old man, gas station attendant, diagnosed with bipolar disorder at age 17. This man had his first episode of mania with mixed and psychotic features at age 17. He had 2 more manic and 4 depressive episodes after his first episode. His current episode was characterized by affective flattening, sad mood, poverty of speech, inability to experience pleasure, anhedonia, lack of desire to engage in relationships, lack of motivation, difficulty falling asleep, difficulty staying asleep, difficulty focusing, reduced ability to concentrate, and some anxiety. He had been referred to a colleague that prescribed lithium 1200 milligrams a day with a good blood level and quetiapine, but he was non-adherent because of nausea, tremor, metallic taste in his mouth coming from lithium, feeling drowsy, tired, and sedated, probably coming from quetiapine. He was saying, I felt sick and drugged. That's why I discontinued the medication. At our assessment, he was sad, mildly agitated, tired, flat, fatigued, with very flat facial expression. He was not having delusions, he was not having hallucinations. The only manic symptom that he was experiencing were some racing thoughts, but nothing major, denies suicidal ideation. The insight was pretty fair. Physical exam, he was normal weight, 180 centimeters high, was sad, a little bit anxious, but primarily depressed. He was diagnosed with bipolar 1 disorder, major depressive episode, moderate to severe, without psychotic features. He didn't meet criteria for mixed features specifier because he had just 1 symptom of mania, some racing thoughts. We decided to start him to begin with valproate twice a day and lorazepam 1 milligram at night to control anxiety and to see how he was doing on a mood stabilizer. He tolerated the medication. He had some improvement, but nothing major. And he came back to us with depressed mood, difficulty concentrating, anhedonia, inability to experience pleasure, pessimistic thoughts, inner tension, and occasional racing thoughts. So we decided to increase valproate to 500 milligrams twice a day, keeping lorazepam at 1 milligram at night, and starting lorazepam as an antidepressant at 20 milligrams right after dinner. The recommended dose, starting dose of lorazepam is 20 milligrams once a day with meals. It needs to be taken with food in order to be absorbed at the best. And then the recommended dose goes between 20 and 60 milligrams, both in monotherapy and adjunctive to lithium or valproate. He tolerated lorazepam very well, with no side effects, and all the symptoms improved, even if they didn't completely clear. So he was still having some depressed mood, difficulty to concentrate, anhedonia, pessimistic thought, inner tension. He had improved, but not yet recovered. So we decided to continue valproate at 500 milligrams twice a day, lorazepam 1 milligram at night. We increased the dose at 40 milligrams right after dinner. After 3 weeks, the patient was still tolerating the medications well, sleep was back to normal. The symptoms of lack of concentration, pessimistic thought, inner tension, depressed mood had clearly improved, but were not completely recovered. So we decided to go to 60 milligrams of lorazepam. We discontinued very gradually lorazepam, given that his sleep was back to normal. So he was on 60 milligrams of lorazepam and divalproex, and he continued to having very good tolerability to lorazepam. All symptoms gradually cleared. Mood was stable and euthymic. Cognitive functions were back to normal. Interest, appetite, sleep, and energy were recovered. It's typical that lorazepam quickly fixes cognition. These patients start thinking differently. Their mind comes bright again. Their mind is again very clean, very clear. And at the same time, this medication is a good antidepressant. In conclusion, bipolar disorder is a prevalent and often chronic condition Bipolar depression is among the active acute episodes of bipolar disorder the most prevalent. Usually patients with bipolar disorder have very long-lasting episodes of depression. It's difficult to treat. We don't have many medications, and lurazidone has proven a clear efficacy and tolerability for bipolar depression. And it is definitely a good tool that has added to our armamentarium to treat bipolar depression. In that it is efficacious, it is well tolerated, and it's relatively fast in terms of how long it takes to bring our patients out from bipolar depression. Thank you very much for your attention.
So, ladies and gentlemen, it's my pleasure to present one of our unique speaker in our conference. He's Dr. Bassem Hamid Mohammed Badr. He's assistant prof and the board certified consultant, psychiatrist, member and fellow of the American Psychiatry Association. He has more than 25 years of experience as well. He's the psychiatrist and head of the department in the Mediclinic and in the Parkview Hospital as well. Dr. Bassem, he worked also as a head of the department at Dubai Hospital and Dubai Health Authority, United Arab Emirates. Not only he played a role in senior roles in the hospital in Dubai, Kuwait, and Egypt, but also he's a lecturer for the Dubai residency and the program for the medical student at Dubai Health Authority as well. He's a talented writer in the field of the social and psychosocial topics as well. Today, he will present for us one of the important topics related to the psychiatry, which is the treatment and treatment-resistant depression, current best practice, and the look for the future. Please welcome Dr. Bassem Hamid Badr with us in our conference.
أهلا وسهلا بكم. أتمنى الجميع يكون safe. Good afternoon, everybody. Assalamu alaikum. Today I will go through treatment-resistant depression. What is the current practice, current best practices, and we have to go through a look for future. What is available weapon in front of resistant depression? Our learning objective, it will be to apply best practices when adjusting treatment for patients with resistant depression, integrate newly available treatment option for depression into clinical practice, describe novel mechanisms of action and clinical trial, result of agent under investigation for treatment of depression. All of us know the first antidepressant to use to treat depression, most probably it will not effective to reach the remission. According to the research work, it is 1/3 of patients achieve remission on their first antidepressant use. Pharmacological treatment algorithm, when we go through a treatment of any depressed patient, we use the first antidepressant. If it is not inefficient or intolerable, we have to switch or do transition or combination or augment. They use the second level of antidepressant. If there is no same situation, it is intolerable or ineffective, we have to switch or augment or do transition or combination. When we reach the third level, we have to consider now if it is not effective. Also, we have to consider augmentation. Theory of multiple mechanisms. Multiple symptoms likely means that multiple brain circuits are involved. All of us know that depression is not only one phase. A lot of symptoms coming in the blue depression, mood disorder. We can find a lot of contradictory symptoms. Some patients come with insomnia, some patients come with hyperinsomnia, with low energy, with irritability. Some patients come with excessive eating. Some patients come with lack of appetite for food. Also, a lot of psychosomatic complaint, a lot of seasonal presentation, a lot of cognitive impairment. So a lot of mosaic of symptoms coming from mosaic of etiology, but still we are using the mechanism of action and rely on the mechanism of action, one mechanism of action. I think better or the most recent research now go through trying to understand what is the circuits behind depression, how to find the solution through targeting different mechanism of action. We have monotherapy with a lot of multiple receptor targeting. For example, mirtazapine, nivazidone, trazodone ER, vilazidone, and vortioxetine. All of us know sometimes one SSRI alone is not effective. Sometimes NRI alone is not effective. And according to the research, only 7% of patients can reach a remission with one SSRI, and 0% can reach the remission with NRI. So if we do combination of both of them, so different mechanism of action, we can reach remission on 54%. Augmentation, there is first line augmentation according the research now, atypical antipsychotic on the top, lithium and thyroid hormone. The second line, another antidepressant with different mechanism, methylphenidate, L-methylfolate, and buspirone, and omega-3 fatty acid. Also, a typical antipsychotic adverse effect we have to go through it very fastly. For example, if we check the sedation, we can find aripiprazole is the best, quetiapine is the worst. Weight gain, brexpiprazole, it is a drug of choice away from weight gain, and olanzapine is the worst one. For extrapyramidal side effect, clozapine is the best, and risperidone is the worst one, and all antipsychotic in between. And we have to take this in consideration when we come to augment, to choose a tolerable antipsychotic for our patient. Also, adjunct medications side effect, for example, lithium with cardiometabolic side effect and sedation, thyroid hormone, there is no side effect. Olanzapine and quetiapine are the worst. When we consider switching and when we consider augmentation, I think we have to consider switching if it is first antidepressant trial, if there is poor tolerated side effect to initial antidepressant, there is no response less than 25%, or there is no time to wait for response. For example, severe condition, patient less functioning, patient prefer to switch. So we go with the patient and the switch. We can consider augmentation if there is 2 or 3 antidepressant trial happens. If the initial antidepressant is well tolerated, at the same time it's effective than more than 25%, there are there is a specific residual symptoms or side effect to the initial antidepressant that can be targeted. There is less time to wait, so we have more severe patient, so we have to take care and make augmentation as fast as you can. Patients prefer augmentation also. This slide will show for us what is beyond monoamine. Monoamine's use, the neuroplasticity hypothesis of depression. All of us know our aim from usage of monoamine to decrease the symptoms. If we look here for the, if we have a look for the duration of treatment of usage of antidepressant, we can find decreasing of the symptoms of depressive improvement of depressive symptoms. It comes with the same time with reaching the high level of monoamines on the day 14 or 13 or 15, as textbook and clinical practice show us. The change in neuroplasticity and glutamatergic neurotransmission, it takes time to happen. More time, it can be start to happen on day 24 or 25. So we can, this can explain us why the patient can complain for us from memory disturbance, from inability to focus for a long time after other symptoms improved. The depressed brain show sign of inadequate neuroplasticity and excessive glutamate. Acting on monoamine system, currently available antidepressant may lead to downstream improvement of neuroplasticity and glutamatergic neurotransmission. But direct targeting glutamatergic neurotransmission or neuroplasticity may lead to fast treatment response. For example, if we use something like ketamine, improve response and remission rate. So it is faster if we go through glutamate receptor directly and improve the glutamatergic neurotransmission. Neuroplasticity and monoamine signaling and brain drive the neurotrophic factor release. It is, if we can see here the monoamine, which is dopamine, working on dopamine, serotonin, whatever, if it come and bind the receptor and release the cascade of hormonal changes inside the cells, the cascade of cell changes, and use the third messenger through calcium dependent protein kinase and protein kinase A, and reaching the activation of cyclic AMP response element binding protein to reach brain drive the neurotrophic factor, which is responsible about synaptogenesis and neuroplasticity and cell survival and neurogenesis. So to reach this total cascade or total aim, or the aim for us to improve the cognition and to improve the neuroplasticity and functionality of the neurons, we need long time to go through all this process of promotion and of second messenger and third messenger. Also, this slide can explain well if we use monoamine regulation, dopamine, serotonin, norepinephrine. The second step, we stimulate calcium kinase, protein kinase, and stimulating cyclic AMP and protein kinase also to reach the activation of cyclic AMP response element binding protein. By the end, we will reach increased expression of AMPA receptor and down regulation of NAMPA receptor to increase the level of binding derivative neurotrophic factor, which is responsible about neuroplasticity, neurogenesis, and full functioning of our receptors and neurons. We reach here to the 3 Gs, which is a new understanding or a new model of action to treat depression through glutamate, GABA, and glycine. Abnormalities of glutamatergic neurotransmission via the NAMPA receptor have a key role in pathogenesis of depression. dysfunction of glutamate signaling, it causes a lot of excitatory glutamate on the certain areas in the brain, which will lead to deficient in one of the causes of depression. And if this glutamate is found in regular and normal level, it will be crucial for synaptic plasticity and learning and memory. Numerous studies have shown regional changes in glutamate receptor as well as elevated level of glutamate in the brain of patients with major depressive disorder, as I said. Normal glutamatergic activity, it is very important for neuroplasticity, and under condition of stress of depression, glutamate signaling is impaired and leading to reduction of neuroplasticity. So this is the scientific and evidence-based science depending on the glutamate theory. So targeting NAMDA receptor, blocking the NAMDA receptor by agent like ketamine will give us very fast improving for depressive symptoms and fast improving and remission for neuroplasticity. Ketamine block NAMDA receptor and also induce, if it's block NAMDA receptor, it will induce schizophrenic-like symptoms because a lot of ketamine will be there. So we can see a lot of psychotic symptoms. But short term, with low dose intravenous ketamine doesn't induce the full range of psychotic symptoms. That's what happened in the step-by-step research to reach something to change our depression in our patient. Ketamine increased synaptic plasticity through mammalian target of rapamycin, which is very crucial and critical intracellular protein that mediates a neuroplasticity and neurotrophic process through blockage of NAMDA receptors and stimulation of AMPA receptor, which lead to increase the neuroplasticity. Sorry. This can, so the antidepressant effect of ketamine or through stimulation of AMPA receptor, not only the blockage of NAMDA receptor. On some research, it is not blocked at all. Attenuation of antidepressant effect of ketamine, it happened if we give naltrexone. So there is effect on opioid receptors. So the antidepressant effect either by targeting opioid receptors or by stimulate the cyclic AMP and inhibit the NAMDA receptor. Something very important, they found the metabolite of ketamine, which is TR6R. It is more effective than ketamine itself in treatment 3 to 4 times in blockage of NAMDA receptor and the treatment of depression with less side effect. This is the rapid efficacy of ketamine in treatment of 18 patients, which is one of the first research used to check ketamine potentiality to treatment of depression. Okay. Safety and the efficacy related to intravenous dopamine, and also which is used on state till now, and it give a lot of good result if 2 times injection per week, and there is no significant difference between 2 times or 3 times per week. Intranasal is ketamine, which is available now in our market, which is approved by the FDA in March, 5th of March 2019, and it is available in Dubai, I think about 6 months ago, and in United Emirates. It show a very significant change in MADRS scores after 1 week of usage ketamine. It's ketamine often. So something we have to take in consideration when we go through esketamine usage, either patient selection, we have to start with select our patient well. We have to make baseline assessment. Our patient must be resistant to the different type of antidepressant. Physical and lab investigation must done for patient before to start the therapy. We have to go through current recommendation and guideline. If there is any potential cardiovascular event or behavioral effect of ketamine. We have also to prepare the treatment setting to be safe for our patient, and all the facility is available if there is something emergent happened. In the nasal spray, we can use 25 to 56 dose for the first time on the first month, then according to our clinical evaluation. We have to consider the safety of our patient. So if there is any history of psychotic symptoms, there is any history of cardiovascular events, we have to take in our consideration. No difference between twice per week to 3 times per week. Also, a new hope for treatment of resistant depression. This is the research is going on using hallucinogens to treatment of depression. For example, psilocybin. The mechanism of action, it is through targeting our agonism on 5-HT2A, which affects the deep cortical layers and the cortical layer V to start the cascade as monoamine oxidase, the monoamine drugs, with reach by the end the NAMDA receptor to block the same and to reach neuroplasticity. This is example for one research happened on about 12 patients with major depressive disorder, severe unipolar. And the result, they start with a screening, do baseline and do functional MRI, and they start with low dose. After 7 days, they give the higher dose of psilocybin, and they follow up after 1 week, then 2 weeks, then 7 weeks with significant improvement. A lot of also research is going right now about the glutamatergic modulator, which targeting the glutamatergic receptor to modulate the receptor to reach the full remission in depression. And they use a lot of stages. There is a lot of still under process, like CB101. There is some side effect here or there. There is some efficacy also in another illness like Alzheimer, as we see here. Also, there is example of another anti-glutamatergic modulator with some moderate evidence. There is some of them in phase 2 and phase 3. And they targeting as a modulator, not the same usual receptor used targeted by glutamate. It is go to novel binding sites. There is initial evidence suggests that this modulation occurs through its potential interaction at unique binding domain near the amino terminal ligand binding interface of the receptor. So maybe if we target the receptor in different site, there is different action and modulation. There is a lot of research about glycine site functional partial agonist versus positive allosteric modulator also. This is under research targeting GABA A receptor. The extrasynaptic benzodiazepine insensitive GABA A receptor through its dependent on stimulation of GABA to inhibit glutamate to improve depression. Two types of GABA A mediated inhibition, either using tonic inhibition or phasic inhibition. Okay. The endogenous opioid also can be target for improvement of depression. The target of the treatment of depression, very important to treat anhedonia. All of us agree anhedonia is one of the resistant symptoms of depression, and it is the most common presented with depressed patients. 75% of our patients complain from anhedonia. And it is, anhedonia has been implicated in the disturbances of central dopaminergic, mesolimbic, and mesocortical reward circuits pathway. Anhedonia and the impaired reward circuit pathway are associated with poorer prognosis and suboptimal treatment response, giving its multimodal mechanism of action as well as cognitive effect of vortioxetine, for example, may contribute toward treatment of anhedonia. Anhedonia, treatment of anhedonia, it is correlated to good functioning of our patients. Vortioxetine is very a new step and very important step forward to treat anhedonia for our depressed patients. Endogenous opioid receptors, mu receptors, delta receptor, and kappa receptors. Mu and delta, it is improved depression in the research, and this is the sites of opioid receptors in the brain and circuits. Mu and delta, as we said, it is antidepressant, has antidepressant effect, and as kappa, it is worsening depressive symptoms. So if we have some medication working on mu and delta and blockage of kappa, it will help us to treat depression. Buprenorphine, which is a medication to treat addiction, and it antagonizes kappa, and it's partially mu opioid agonist. There is some antidepressant effect of this medication. A lot of research working on this medication to treat depression, and one research about buprenorphine related the decreasing suicidal risk of some patients with suicidal ideation. Also, it is better than placebo. It's found better than placebo. Its combination with buprenorphine and some samidorphan for treatment of depression with some nausea and dizziness and fatigue side effect. This is the most common side effect. So other targets of depression treatment, maybe it's acetylcholine, working on acetylcholine inhibitor and a neurotransmitter blocking agent. Acetylcholine muscarinic receptor antagonist also can give us help, and there is research working on this. Corticosteroid receptor antagonist and emergent somatic symptoms, somatic treatment, for example, deeping transmagnetic using transmagnetic stimulation and positive repetitive transcranial magnetic stimulation, synchronizing transcranial magnetic stimulation, low field magnetic stimulation. So neurobiological substrate of depression may be beyond monoaminergic circuits, glutamatergic targets like ketamine, esketamine, and all of other moods, tools to treatment depression. It is our goal right now. Opioid agent also show some benefits, so a lot of research going on. Additional research is needed to validate all these targets. Thank you, and hope I summarize our approach, a new approach to target resistant patients with depression, and thanks for your attendance.
Okay, so we need to thank Dr. Bassam on his valid lectures, and now it's my pleasure again to represent myself and my mentor and leader, Dr. Medhat Al-Sabahi, who's the principal investigator on this research as well. So I will talk briefly about the relapse rate among the rehabilitation patient during the April 2020 in comparison to the same period in 2019 in Behavior Science Pavilion, Sheikh Khalifa Medical City, United Arab Emirates, and its retrospective study. So briefly regarding the background, as we know, the goals for rehabilitation service is to re-enroll the patient to the society and to help him to develop their emotional, social, and intellectual skills with the less or without the input of the professional support or service as well. And as we know, being the stable mental situation and social stability as well, it's the aim for the rehabilitation unit. And there is a difficult to reassess or to assess the rate of the relapse among the rehab patients because of the nature of the mental illness, in addition to the multidisciplinary care plan input. So we use regarding the method, we collect the file from all the rehabilitation patients, the patient on the rehab unit and Behavior Science Pavilion, the patient who attend the day center program, day center clinic, and the patient who assigned for the home visit. We put the exclusion criteria. We exclude the patient who's below 18 years old. We exclude the patient above 65 years old, the geriatric patient. And we exclude the patient with learning disability. We exclude the patient with current or ongoing substance misuse or problem. And we exclude the patient with the current and ongoing forensic history as well, forensic cases as well. So we collect the data regarding the age, the gender, the patient if he's on oral medication or long-acting medication, the present of the other therapy like the psychology sessions, occupational therapy sessions as well. And we count the present of the need to revise the care plan, either to add the medication, and we add the present of the admission to inpatient unit as well. So our result shows that the patient who's on the long-acting injection shows the less relapse rate in comparison to the patient who's only on the oral medication. And we found there is no correlation between the frequency of the injectable antipsychotic and the relapse rate. And we found that the patient with established diagnosis of schizophrenia shows the highest relapse rate in comparison to the other mental illness like the bipolar, general anxiety disorder, and other mental illness. And we found that the patient with established diagnosis of schizophrenia who's taking the paliperidone injection, the paliperidone long-acting injections, they show less relapse rate in comparison to the other long-acting injection as well. So briefly, as a recommendation, we recommend early detect the patient who's suitable for the long-acting, especially the patient with the adherence problem, the patient with compliant issue, And we recommend all the psychiatrists to clearly document the medication history, the nature of the illnesses, and if there is any compliant issue with the medication. And we recommend the psychiatrist to comprehensively provide the psychoeducation for the patient and family as well. This is the recommendation which we included, and at the end we add our reference for this poster. So with this poster, with this presentation, we end up with our panel for now, and we will take some break, and we'll continue with our valid lecture as well. Thank you very much for your attention.
Thank you for inviting me to speak with you today. I'm really sorry that I cannot be with you in person. I'd love to be with you. In these COVID times and with the Australian border restriction, it leaves me coming to you from my home in Queensland, Australia. In the spirit of reconciliation, I would like to acknowledge the traditional custodians of my country and their connection to land, sea and community. I pay my respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples either listening today or there in person. I live on Quandamooka country and took this background picture this morning to share with you the beauty of the country where I live. I want to also acknowledge those of us who share our wisdom from our struggle and triumph over the impacts of mental ill health and the use of this wisdom in our advocacy to influence the upholding of human rights-based approaches and person-led practices within our mental health services. This has been my passion and advocacy for many decades, and the advocacy of many lived experience leaders from around the world. I ask you to join with me to consider a sticky problem that may have been keeping help providers and help seekers somewhat stuck. This sticky or wicked problem will not be solved with more of the same solutions. The concept of empowerment has been a cornerstone concept within most social movements, not least within the lived experience-driven mental health recovery reform agendas. Even as a social worker, I should be rah-rah empowerment, but something about how we have operationalised this concept does not sit well with me. As someone with a lengthy lived experience, I appreciate now more than ever before that no one but myself can motivate me or empower me in my recovery process or self-writing process. So in this presentation, I want to explore and articulate the importance of personal agency to living well. I want us to reconceptualize the notions of empowerment and motivation within psychosocial service delivery and identify some of the components of psychosocial services and practices that might need either to be redesigned, relinquished, or stretched a little within a VUCA context. VUCA is a term that our business and leaders understand well, and volatility, uncertainty, complexity, and ambiguity. We are living in VUCA moments and in VUCA times. Many professionals and services have shifted their way of working to activate recovery to a state of empowerment with all good intentions, but sadly, often without sustainable success. Such external activation no longer serves many of us living in these VUCA times. I want to argue that others, no matter how good meaning we are, cannot empower nor motivate anyone to recover. Services that have dared to shift to this focus have not found it easy. If anything, it's very challenging. But yet they've found it reinvigorating and ultimately worth it. When I work with organisations and help providers, help seekers, I have a habit of asking questions, lots of questions. Sometimes some people call me a dog with a bone. When I meet with health providers in the mental health field, one of my go-to questions is asking them about what is your role in a person's life? They usually tell me their job title. I'm a peer worker, I'm a peer specialist, I'm a psychiatrist, I'm a consultant psychiatrist, I'm a social worker, I'm a counsellor, I'm a psychologist, I'm a clinical psychologist, I'm an occupational therapist, I'm a nurse, I'm a support coordinator, I'm a support worker, etc., etc. I usually reply that this is your job title, but I'd love to hear about your role in someone's life. This leaves most people a little perplexed and somewhat fluxed as they stumble to find words. Well, I assess what's wrong. I prescribe medication. I watch them take medication. I observe them. I provide activities for them to do. I assess their functioning. I establish goals with them. I develop a plan, a recovery plan, a service plan, a care plan. I find them housing. I review how they're going. I find them work. I talk to them about their problems. I talk to their families about the problems. I help them get back into education. I take them to the community. I really encourage them to get involved in activities. When I can't help, I refer them to other agencies. I try to keep people safe. I give them hope. I motivate them to want something different in their life, to do something different. My role, I suppose you could say, is to empower them. I love this comic. If you're good and do exactly as I say, I shall empower you. When I ask help seekers about how they understand why they have various help providers in their life, they either can't tell me or they tell me what they do and not why they do it. They take me to coffee. They ask me lots of questions. They take me to places I need to go. They monitor my symptoms. They provide activities for me to do or groups to go to. They keep me safe. They push me to do things even when I'm not interested or I don't want to because they say it's good for me to try. What I don't hear from those that are seeking help, that they are helping me to overcome the things that stand in my way, the things I find difficult in being able to lead and live my life. They're helping me get spectacularly good at those things. Our actions as help providers are based on our fundamental belief about our role in relation to people's potential. Trying to empower someone through either the fairy godmother role or the whip role only serves to maintain the status quo for all. Who might need to change here may not be the help seeker, it may be the help provider. Let me share you a story. I had the privilege of working with an assertive outreach team who wanted to discover better ways of working with people. Many people had been in their service for years, sometimes decades, without visible change. For some, they had even deteriorated, triggering more and more helpers into their life. This team followed standard operating procedures that had mostly turned into routine practices. They did assessments, care planning, monitoring, support interventions, review progress, replanning, etc. And the cycle goes on. I asked them to be brave and try something different. I asked them to invite people, help seekers, to help them solve a problem. So 8 help seekers gathered, with help providers sitting on the outside of the room. I explained to the help seekers that their help providers needed their help. They wanted to understand their role in their life. This seems like such an obvious answer, but the answers were enlightening for the team. They said ultimately the role of the helping professional was to monitor them and keep them under the Mental Health Act. The help providers listening were shocked at this response. Later they reflected, how did they get that message from us? We don't tell them that that's what our role is. If anything, we want to help them get off the Mental Health Act. They came to realise that this message of monitoring and staying on the Mental Health Act was because they never ever talked about getting off the Mental Health Act. And as a result of this realisation, they developed new procedures and fresh conversations that ensured that people knew their role was to help them get really good at overcoming the risk and vulnerabilities that kept them under the Mental Health Act. In one team, over time, the work on being clear in their role in people's lives saw most people no longer being detained under the Mental Health Act and ultimately taking up new life opportunities despite the presence of mental illness symptoms. Yes, this work was challenging, it wasn't quick, but it was right. It was not about shifting people, but shifting how health professionals got clear in their purpose and changed their way of working. They stopped trying to activate, empower, and motivate people. I was doodling this term empower, trying to write a piece about this concept a few years ago, but was struggling to articulate it. On my notebook, I crossed out the EM, and it left the word power, recognizing the essence of this term, and turned it around as me power. Me power is an effort of renegotiating and reclaiming my sense of self-expertise, self-leadership, self-knowledge, and self-writing within the context of my relationships, my life roles and opportunities, regardless of the presence or absence of distress. Me power reinforces that it comes from within. It is our personal agency. We were born with it. We were born with this power. We can't get any more of it. It can be atrophied by ourselves and others, but it is always there and has always been there. We can't add to it. It's like a muscle that has been atrophied in a cast after a broken bone. We can strengthen its use. Others can't strengthen it for us. Sadly, it would be nice sometimes if they could. But what others or helping professionals can do is create opportunities for us to exercise it like a muscle, exercise our me power muscle within, like in a gym. But first of all, as helping professionals, we have to recognise its existence. I'm involved in a project, Mind Life, in Australia, and it's been raising critical, crucial conversations with health providers and help seekers. In particular, developing resources so that both help providers and help seekers can avoid the pitfalls in their helping encounter. There are 15 mindsets that we ponder on, but it's this one that raises much emotion. We cannot empower or motivate anyone but ourselves, but we can easily disempower or demotivate. This provocative statement kind of brings out so much angst. From some people we hear, but we do empower people. Others say, it's my job to empower. If I don't do it, who is? One experienced health provider said that he agreed with the second part of the statement, but not the first. To go back to those distressed health providers in the Mind Life Critical Crucial Conversations, we asked them a question: who motivates or empowers you? This question is usually met with a stumped look, and then a slow realization comes across their face that they realize that their sense of empowerment and motivation has come from within them. It cannot but be for them nor for anyone else, and especially for those who seek support from them. It is this very realization that allows them to let go of their need to motivate and empower others. There's one Mind Life help provider who went back to their service, to their team, and she used to ask them, how have you helped today? What have you done for this person today? How have you worked towards their goals today? And she realized she was asking the wrong question. She flipped her question. So at the end of each day, she'd ask the team, how have you not got in someone's way today? How have you not disabled someone today? How have you not disempowered them or demotivated them? How have you not stolen their goals from them and made them your own work? This reframing of the question helped others to get really clear that on one hand they can help, and on the other hand they can hinder, and they always have to be mindful about that. I want to come back to think through with you the relationship between our human needs and motivation. And it won't be a surprise to many of you to hear and to reinforce the concept that all our needs theories, no matter what theorists you think about, are actually motivation theories. And all motivation theories, at the heart of them, are needs that drive our motivation. We all have the same human needs. Doesn't matter whether we're young, old, black, blue, white, red, live in the Arctic Circle, live in the Antarctic. We all have the same human needs. And everything that we do every day is an attempt or an initiative to try and meet one or more of our needs. When we go to a help providing service, one truth we'll have is that we will have a boulder. We'll have a need that we're not able to meet within our own resources, that we're looking from someone else to help us to meet it. Now, that doesn't matter whether it's the baker, the butcher, a library, a legal service, a friend, or a psychosocial support service. At the end of the day, we want something that helps us meet our need, but there's something in the way. I call these things boulders. Boulders are things that stand in our way that make it difficult to proceed. Sometimes they come from with us. They're our internal perceptions or our behaviours, or sometimes they're external structures. They can be other people. They can be lost opportunities. They can be things that make it challenging for us to meet our psychosocial needs. They then become our psychosocial challenges. Now, even when someone comes to a service for help, and the last thing we need to be asking them is, what are your goals? You have to deeply understand what the boulder is that's bringing there. What is the psychosocial challenge that they're struggling with that they actually want to be able to overcome? When we ask them just about their goals, the challenge is that they'll be able to name those off because they've been asked 100 times before. They might not even know the nature of their boulder there. And if those that interact with us also aren't aware of the boulder and see that their role is just to activate someone to that, they might be successful in trying to meet some of those goals, but it's actually an illusion because what has changed is nothing. The boulder is still the same, if not bigger. So when you have someone who really understands the work of psychosocial supports is not in goal attainment, but helping someone become more masterful in overcoming the psychosocial challenges, they'll ask different questions. They will think to themselves, if they could have done it, they would have done it. I wonder what's getting in the way. Where is this difficult? What's keeping the status quo here? What is making this so difficult for someone to meet their human needs without actually coming to a helping service? So the role of a helping service is really to understand the nature of the boulder with the person and then create opportunities like a gym for someone to get spectacularly good at maximising their ability to overcome it. So some of the things that can stand in our way are those structural barriers, limited personal resources, lost opportunities, fear, limited or no support, other people. I can remember I asked this to a group of people with lived experience once, and they named off 2 whiteboards full of reasons that it was difficult for them to live and lead a life like everyone else. Can't get a boyfriend, can't get a girlfriend, can't go on holidays, don't have enough money for this. There was this one person who dared to say, my boulder is that I have lost my ability to stand back up. And I said, say that again? She said, my boulder is that I have lost my ability to stand back up. Such a powerful thing. If I do not know how to stand back up, I can't take a step. This is a really important point because our job in someone's life is not to stop them falling, but more importantly, how to get back up. Because we live in a world that we cannot protect ourselves from falling 24 hours a day, 7 days a week. And the greatest gift we can give to someone is to help them stand back up. How do we help someone navigate their boulder so that when they get another one, and you and I and everyone else will, we have more agency, more belief, more sense of control that we know that we can manage this. This doesn't mean that we'll never need support again, but I get excited when I recognise I can do this, not necessarily my goal attainment. People say to me, Helen, we can tell you we can tell that you've recovered, and go, oh, that's interesting. How do you tell that? Well, you've got a husband and you work and you look functioning. I had a group of people say, well, you look relatively well groomed. I said, they're all illusions, total illusions of my recovery. If I cannot influence on a day-to-day basis the things that stand in my way. And for me, that's the most important thing and the greatest gift that we can give to another. One organisation that I'm working with has really tried hard to shift away from destination goals. They've done two things. They've changed their planning process to be accountability plans. So instead of planning about people's goals, they're having deep conversations around what's getting in the way for people. But instead of writing a service plan or a recovery plan for the person, they're writing a worker's plan, a coach's plan about what the supports and interventions that the person can hold them accountable for delivering, in the aim of creating an environment that maximises their self-writing capacity. Second thing, they've changed their agency around expectation and culture around the group environment that they operate from. It used to be a drop-in centre where people would come in the morning and leave in the afternoon and nothing changed. And now there's an expectation that someone will come in and name what they want to leave with today, what they want to get stronger at, what they want to get better with, what requests they have for help. And they put that on one board. And on the other board, when they leave and check out in the afternoon, they move it across if they've got it. So it's really interesting to recognise that now people come with the expectation that this is a space that they've come to get spectacularly good at something, not a place to be rested and supported and just to stay safe. And this brings us to the why now. As before, I've mentioned this word VUCA, and we're living in VUCA times now. The volatility, the uncertainty, the complexity, and the ambiguity. We have a moral obligation to create opportunities where people can navigate their VUCA environments, not our service environments, not to stay small and stay safe, but to live a life now. We have to have the trait of adaptability. It is the greatest trait that leaders look for, and in our own personal world, if we do not have that ability to adapt, then we're probably going to get somewhat stuck. And I want to borrow from Heifetz's work. I've been very influenced by his work in the leadership space, and think about what does this look like in our self-leadership space. And he talks about one of the roles to creating productive zones or change in our lives or change in a workforce is to create what we call a productive zone of disequilibrium. It means we have to stretch a little bit beyond our comfort zone, but not too hot and not too cold. Change happens when we can create this productive zone of disequilibrium. We know that we get no more sense of mastery and control in our lives. We don't get this sense of I rock, I can do this, by doing our everyday things well. Shopping, cleaning, going to work, routine things. I don't get any sense of mastery just because I do them spectacularly well. But I can lose a sense of mastery and personal control by not even having that opportunity to do them, by failing to be able to do things well, those routine things. My sense of mastery and control comes from, and only comes from, when I stretch a little bit outside my comfort zone. And when I stretch a little bit outside my comfort zone, I recognise this growing space. I recognise my adaptability. I recognise my agency. I recognise myself outside of the context of my limitations. I want to share a story with you. A friend of mine, Sarah, who inspires me and reminds me every day of the personal effort it takes to master risk and vulnerability. Sarah finds herself in sticky situations when she believes others are poisoning her food and water. She has her own coping strategies of drinking and eating only from sealed containers. Sometimes she can't manage this enough and ends up being admitted to hospital. This last admission, she stayed a month. But as hospitals do, she was only given sealed food and water, therefore was not under any distress. A safety zone was created, reinforcing to her that she was right to resist taking food and water in any other way. No one tried to create a productive zone of disequilibrium for her, where she could develop further mastery and adaptability. A few weeks after discharge, the same fear returned. She rang me and said, "Hey, Hal, I'm just going to jump in my car and drive to a new place to live and start again, where no one knows me and no one can poison my food and water." I said to her that was one option, but I also offered her to come and stay with me for a few days. I promised her I would not keep her safe, and she knew what I meant by this. When she arrived, she was clutching her can of drink, as she knew it was harder to pierce a can than a plastic one. I asked her what was going to be her stretch while she was here, and if I could help in any way. She didn't really know what her stretch was. She was full with fear. We worked through a stretch range for her. I asked her, if you were to put that drink down and go outside for 60 seconds, would it be a stretch to come back in and drink your drink? She said that would be far too challenging. Great, I said. We've found a stretch to ping, a stretch that's too hot. What about if you sit there and shut your eyes and hold the drink can for 60 seconds and then drink it? Would that be a stretch? No, she said, that would be easy. Great, you found the tepid water. You found something you can already do. No good practicing that. What about if you put the drink on the table, stayed here, shut your eyes, and then drank it after 60 seconds? Would that be a stretch? And she said, would you be in the room or not? And I said, well, that depends. Which one would be a stretch? And she said, well, if you weren't in the room, that would be easy peasy. But if you were here with me, it would be a stretch. So she did. The next morning, Sarah got up and she said to me, did you notice I left an open can in the fridge last night and I drank it this morning? And I said to her, no, actually I didn't. I wasn't monitoring you. And she said, well, yeah, I did. And wow, I can do this. And she went around about her day. And later that day, she came to me and she said, I think I've got this now. I think I'm ready to go home. And that was only 36 hours after she came to stay. She did the work. She stretched herself. She reclaimed her agency once again. On parting, she said the most amazing thing to me that I think is the essence of what we're talking about when we're really talking about personal agency and recovery. She said to me, I do not know my recovery effort, my me power, by either the presence or absence of symptoms. I only know my me power when I re-experience symptoms qualitatively differently. Our mental health systems of care have an urgent obligation to stretch their focus beyond crisis, beyond care, beyond concern, and beyond containment, to intentionally create opportunities where people who experience psychosocial challenges leave with the personal agency, confidence, and capacity to navigate life's VUCA moments well. Thank you for your time, and I invite you into a conversation and questions.
So now we have a presentation by Dr. Hadir Abdulrahman. Hadir is one of our senior specialists. I'm proud to have her in my team. She holds both Arab Board in Psychiatry and the membership of Royal College of Psychiatrists. She's the team lead of ECT in our facility.
Good afternoon. Thank you, Dr. Aisha. It's a great pleasure to be with all of you here virtually today. I was supposed to be physically there, then due to the pandemic, the PCR results were not out, so I'm not allowed physically on the spot. So it gives me great pleasure, honestly, introducing this piece of work that we work together in BSP, the Behavioral Science Pavilion, with the team, Dr. Aisha Duferi, Dr. Reem Abdelkader, Dr. Muhammad Al-Khaldi, and Dr. Iman Al-Houthi. We looked into the patterns of hospitalization during the first 3 years of psychosis. The objectives were to describe the psychotropic prescription patterns and the rehospitalization and re-engagement patterns for patients presenting with first episode psychosis during the first 3 years of the illness. It was a prospective cohort study. Medical records of newly treated patients with first episode psychosis presenting to the outpatient and inpatient units of the Behavioral Science Pavilion in Abu Dhabi. It took place from, we took the patients from June 2016 to March 2017, and they were all reviewed for 3 years. We excluded any patients above 65 years. We excluded patients with neurodevelopmental and neurocognitive disorders. We also excluded patients who did not follow up in the same facility after discharge or after the first clinic appointment. We also excluded patients with substance-induced psychosis. We came out with a total of 57 patients. Most of the patients, 52%, were single. And in regards to the gender, we had a 55% males with a 44% that were females. Regarding the ethnicity, most were Arab, 80%. This was followed by Asian and Africans. Most of them were non-smokers, nearly 70%. 50% were high school educated and nearly also 50% were unemployed. This was followed by about 12% that were professional. As seen in this figure, the sample was from 14 of age until 56 years of age with a mean of 29 years. 42% of the sample did not have any history of psychotic illness. This was followed by 23% with a family history of a psychotic illness, and 33% it wasn't documented in the files. Most of the patients that presented to were actually through the inpatient facility, they were admitted, so nearly 83%. Only 16% with those with the first episode psychosis were found in the outpatient facility. Most were referred by family members, nearly 75%. This was followed by self-referred, and then those that came with the help of authorities, usually the police. As seen in the figure, when we looked into the end diagnosis, it was found that about 41% was bipolar affective disorder. This was the most common diagnosis, followed by schizophrenia. Then comes other depression with psychotic features, delusional disorder, and schizoaffective disorder. So in total, 43% had non-affective psychosis. We looked into details about their antipsychotic prescription patterns in the beginning of the study and at the end of the 3 years. In the beginning of the study, the first antipsychotic that was prescribed was actually analyzed for all of the patients, and it was found that more than 50% of our patients, we usually start them on olanzapine. This was followed by other oral antipsychotics. The next common one was paliperidone, but at a low of 8.9%. Polypharmacy was found in a few patients, and we'll come into this in a few minutes. Depot injections was only 3.6% as an initiation strategy, either at the end of the first discharge or after the first clinic visit. When we looked and compared the results after 3 years, we found that olanzapine is still the most common antipsychotic that is used alone, but it was reduced to 26.8%. There was a clear increase in the depot injections use. Clozapine also was about 5.4%. We did not find any significant correlation between the antipsychotic that was used and the discontinuation rate that we'll come to talk to in a few minutes. There was a clear increase in antipsychotic polypharmacy after 3 years from a 16.2% to a 28.8%. So nearly about 30% of the patients in 3 years, they end up having depot injections. They end up having antipsychotics, two or more antipsychotics. Now, in regards to the depot injections, we started with 3.6% and we ended up with about 20% of the patients. So in the first encounter, only 3.6% of the patients were initiated on a depot injections. This was about nearly 20% at the end of the 3 years. At the end of the 3 years, those on depot injections, only about 40% of them were both on the depot injection plus another antipsychotic. However, 60% was solely on only a depot injection. Looking in more details, we found that most of the changes to the antipsychotics was only done during the first month of initiation, and nearly 35% of the patients actually remained on the same antipsychotic for the whole period of the 3 years. We looked into other medications that are prescribed beside the antipsychotics. So the blue represents those medications that were prescribed in the beginning of the study. The orange presents the medications that were prescribed at the end of the 3 years. There was a very clear decrease and reduction in the benzodiazepine use after 3 years. So understandably, most of the patients were started on benzodiazepines in the beginning. However, there was less than 10% of them, or maybe 6%, that were on the only benzodiazepines at the end of the 3 years. There was a slight increase in the mood stabilizer use, nearly the same use of antidepressants and propranolol and zopiclone. There was a reduction in the use of anticholinergics in the end of the study. More patients had ECT at the end of the study. Only 2% of the patients were initiated ECT in the beginning, probably due to emergency use. By the end of the 3 years, about 14% of the sample had undergone an ECT treatment. When we came to talk about the comorbid medical conditions, we actually analyzed the comorbid medical conditions when the patient first visited the hospital and then after 3 years. And we found out that most of the patients, nearly 85% of them, did not have any comorbid conditions in the beginning of the study. This was clearly reduced to 65% by the end of the study. Diabetes mellitus increased from a 5% to nearly 12% by the end of the study. And there was a clear increase in obesity and those with multiple comorbid conditions. Hypertension also was increased, but not as the other medical conditions. We looked into the follow-up rate for patients in the outpatient clinic. We described no-show as a patient that lost follow-up for more than 3 months, given that we are allowed to prescribe medications up to 3 months in our facility. And it was found that nearly 35% of the patients never missed a clinic appointment. Most of the patients actually visited the hospital, and 15% missed an appointment nearly every year. When we looked more about the engagement and re-engagement, as mentioned earlier, 35% of the patients had no discontinuation and they visited the hospital for all their clinic appointments. However, most of the patients did re-engage after discontinuation within 6 months to 1 year. This was either due to a relapse of symptoms in the outpatient clinic or due to readmission. 12% never re-engaged after discontinuation. The average number of admissions that were found during the 3 years was 2.3 admissions. So 44% of the patients had an average of 2 admissions during the 3 years. There was a few patients that had more than 8 admissions during the 3 year of the study. The average length of hospitalization was found to be 14 days. 77% of the patients were not readmitted, and 77% of our patients were readmitted, and 23% of our patients were not readmitted during the 3 years of the study. We looked into the correlations with rehospitalization, so we found that bipolar and schizophrenia patients had a significantly higher readmission rate compared to other diagnoses. Male readmission rate was significantly higher with a p-value of 0.047 compared to female readmission rate. Length of stay for widowed patients was significantly higher than other patients and other marital status. Patients taking olanzapine and paliperidone as their first antipsychotics had a significantly higher total days of admission compared to others. Patients ending up with clozapine had a significantly higher number of admissions during the 3 years, of course, understandably, probably due to the severity of their illness. And patients with mood stabilizers at the end of the 3 years had a significantly higher number of admissions. When we looked at the end outcome at the end of the 3 years, we found that nearly 80% or more than 80% of the patients, they had no psychotic residual symptoms. And there was a significant reduction in the psychotic symptoms for the patients in general. A few number of patients had residual symptoms of psychosis. Very few had residual negative symptoms, and only one patient had residual both positive and negative symptoms of psychosis. These were our references, and we are open for any questions. Thank you very much.
Thank you, Dr. Hadir, for this presentation. Although it seems to be a replicated work, not important to a lot of people, but when we put it in the context of having lack of data in this part of the world, it's very important, and this data is of value, and it's worth publishing and comparing to the international figures. We'll skip the question part because we run out of time. Now we'll have again a poster presentation by another colleague, Dr. Ala again. She will present a poster presentation about some study she's done in behavioral science.
Hi, this is Dr. Najat Al-Zubaydi, specialist psychiatrist from Sheikh Khalifa Medical City at Behavioral Science Pavilion in Abu Dhabi, United Arab Emirates. On the behalf of my team, Dr. Midhat Al-Sabbahi, Dr. Nofel Kindi, Dr. Amna Al-Mismari, and Dr. Ala Al-Naqbi, who will be joining, it is my honor to present to you the poster of our study, which is the relapse rate among patients with established diagnoses of schizophrenia who are on long-acting injections under rehabilitation psychiatry in SKMC Behavioral Science Pavilion during April 2019 comparing to April 2020. This is a retrospective record review. Going to background, non-adherence is an important factor in therapeutic failure, which is frequently correlated with disease progression. In case of mental illness and schizophrenia in particular, non-adherence reaches up to 75%. Medication non-adherence is associated with poor outcomes, more hospital readmissions, and increased cost of care. Poor medication adherence is multifactorial, is caused by lack of insight or the persistence of psychotic symptoms. Method. All patients with established diagnoses of schizophrenia on long-acting injection who are attending rehabilitation psychiatric unit, including day center, home visit, and day center clinic during the period of April 2019 and the same month in 2020. The medical records of those patients were reviewed to determine any correlations. Data analyzed through defined variable including age, gender, type of antipsychotic, type of long-acting antipsychotic, frequency of admissions, number of visits, the presence of oral antipsychotic, presence of other therapies as psychotherapy and or occupational therapy sessions, need of admission, and need of care plan change.
So regarding the result and conclusion, it shows that the biliprid 100 milligram Q4 weeks is the most long-acting antipsychotic medication used in the rehabilitation unit. The other result shows the patient with established diagnosis of schizophrenia showed a high rate in comparison to the other subtype of schizophrenia. So the patient with paranoid type schizophrenia shows the highest relapse rate in comparison to other subtype of the schizophrenia. And also the patient with established diagnosis of the schizophrenia or long-acting show the early relapse symptoms with no admission during the April 2020 in comparison to the April 2019 as well. We found no correlation between the adding oral medication on top of the antipsychotic and the relapse rate. We show no correlation between the receiving the other therapy such as the psychology sessions and occupational therapy and the relapse rate as well. We recommend the early determine the need of the introduced long-acting injection, especially with the patient with the compliance issue and adherence issue. And we recommend to consider revising the care plan during the health pandemic to prevent any sign of the relapse, so we can prevent the admission during the critical health period. To consider the psychoeducation, especially for the patient's family, to prevent to detect or to catch any early sign of the relapse as well. Thank you very much.
We're sorry for the technical problem. We could not illustrate the poster. So now from Singapore we have Professor Tan, who served as the head of occupational therapy department at the Institute of Mental Health. Currently she's an associate professor and director of program at the Health and Social Science Cluster in Singapore Institute of Technology. She's in charge of all allied health and nursing programs at the Institute and teaches mental health in the occupational therapy program. Please welcome with me Professor Tan.
Hello everyone, I am Associate Professor Bing Li Tan and I am the Director of Programs at the Singapore Institute of Technology. I also hold a joint appointment at the Occupational Therapy Department at the Institute of Mental Health. My presentation is on Evidence and Experiences, using games and technology in psychosocial rehabilitation for persons with serious mental health conditions. These are my disclosures. During my presentation, I will talk about two of my research studies and these are the funding sources. I will also share some initiatives by occupational therapy colleagues at the Institute of Mental Health in Singapore. This is an outline of my presentation. And the learning objectives are to gain an understanding of the therapeutic use of gamified platform for cognitive rehabilitation and functional training, to describe examples of games and technology used in psychosocial rehabilitation, to apply strategies in transfer of learning from games to everyday living, and to have an understanding of how to conduct group skills training via online remote platforms. I'm sure many of you remember the Pokemon craze a few years ago. Living in this technologically advanced society, especially now with COVID-19, we rely a lot on technology and games in everyday living as well as for personal entertainment. Some of the service users that I know of speak about their time spent on the internet, on social media, or on games, even though they may have mood or motivation issues that affect their ability to assume meaningful life roles. Hence, one of the ways to engage these service users is through games that are attractive, engaging, and can help improve their functioning and participation at work, community living, or leisure. This is a photo of me using a virtual reality headset. If you have tried this before, you will know how immersive such an experience can be, and it can create a new dimension for us to experience novel scenarios without being in a real-life situation. Therefore, games are favored in psychosocial rehabilitation because they can provide prompt and accurate feedback on the user performance. They can also be highly structured to target specific areas. They have attractive visual images, and you can increase the level of challenge of each task. In terms of evidence, meta-analysis has also reported larger effect size for cognitive rehabilitation conducted using gamified computer exercises compared to paper and pencil exercises. In psychosocial rehabilitation, games can be used in the following ways. Firstly, they are very popular in cognitive rehabilitation, either targeting specific cognitive skills or to utilize all cognitive skills to accomplish certain tasks. Secondly, games can be used as part of functional training in order to train service users to perform meaningful tasks necessary for role attainment. These may include vocational or community living tasks. It is very important to highlight that as mental health practitioners, we do not just provide games for service users to play. We need to first set long-term and short-term rehabilitation goals with service users, then ascertain how games will help achieve the rehabilitation goals. We need to be clear whether we are conducting a cognitive rehabilitation intervention and whether we have the necessary skills and training to incorporate gamified activities as part of a cognitive rehabilitation intervention. If we are doing functional training, we also need to be clear on the real-life functional outcomes that we hope to achieve. Lastly, we need to determine the rehabilitation approach to use. When we decide to use gamified platforms to restore cognitive skills or functional skills, we will also determine whether we are using the rehearsal or strategy approach, and whether we are restoring in a top-down or bottom-up manner. I will illustrate with examples later. Next, we will also need to ask whether it is realistic to train our service user to improve all the skills, or we should teach service users how to compensate for their difficulties or modify the environment to improve functional performance. To me, the most crucial element is that we need to think about how do we help the service user to transfer what they have learned in these games to their everyday living, in particular to the meaningful activities that they wish to participate in. Back in 2013, I published this randomized controlled study, which the intervention group went through 60 hours of cognitive remediation, while the placebo group participated in physical exercises. At that time, the cognitive remediation program utilized an older cognitive rehab software called the PSS Cog Rehab. This is one of the memory games. The user is supposed to remember a phone message, either visually or verbally presented, or both. Then the user needs to answer questions about this phone message. If we utilize the rehearsal method, we will be asking the user to repeat and practice this game several times until the user is able to remember more pieces of information. However, if we utilize the strategy method, we will be teaching the user strategies to accomplish this game. For example, we may get the user to visualize a man with the word Bill on his t-shirt standing in a park and holding a phone with Monday 2 p.m. written on it. Sometimes there's a limit to the amount of information that the service user can remember. So instead of forcing him or her to improve the memory further, we may use a compensatory approach and teach the person to jot down the information on a notepad so that he or she learns how to take down information in real-life situations if working memory is an issue. For this particular research study, all the participants were either undergoing vocational rehabilitation or community living skills training at the day center. It was crucial for them to utilize whatever they had learned during cognitive games to their rehabilitation programs. So, for example, if a participant had learned the strategy of visualization to memorize items and he was training in a cafe, the occupational therapist would actively get him to remember food orders and prompt him to use the strategy of visualization. Such transfer of learning is necessary so that functional gains can be achieved. This also means that the professional conducting the gamified cognitive rehab sessions need to communicate closely with the professional delivering the vocational rehabilitation program. Results of this study showed that participants who received cognitive remediation had significantly greater attainment of vocational skills for those undergoing vocational rehabilitation. Among those receiving services at the day center, they attained greater independent living skills than the physical exercise control group. The cognitive remediation participants also worked longer hours in open employment and had better community ability post-intervention and at the end of the 1-year follow-up. Moving on to the use of games for functional training, there are some features we should take note of. Such games should be contextualized to the service user's functional domains and provide multi-sensory experience. This is a research project that is currently in progress. We are developing an augmented reality game to train persons with cognitive impairment to fulfill job requirements in a cafe setting. The principles of neuropsychological and educational approach to remediation, or NEAR for short, is adopted in this study. Many service users with the mental health conditions are trained to work in the food and beverage setting. Hence, this game provides them with a contextualized experience in a safe environment. Users are given visual as well as auditory instructions, and feedback is also given in the form of auditory cues. Again, the emphasis is for the service users to acquire strategies to fulfill the job demands in the augmented reality platform, followed by transfer of learning to their real-world environment. Besides the gamified sessions, the occupational therapists also conduct bridging groups to get service users to generalize their learning to daily lives. Another game created a few years ago by my colleagues at the Institute of Mental Health in Singapore was about teaching service users who were in a prison psychiatric or a hospital forensic psychiatry setting about how to navigate the community upon release from the facility. Thus, contextualization to current landmarks, facilities, and services in Singapore was necessary. This game was targeted at service users with psychiatric and neurodevelopmental problems who might have difficulties in retaining information through traditional psychoeducation methods. Hence, a gamified platform to help them learn actively was useful. Part of this game involves getting the user to learn about the locations of primary care providers, we call them polyclinics in Singapore, particularly those near their homes. They might also not be updated about the new underground lines and stations, we call them the MRT in Singapore. So the game was meant to introduce these essential resources in a fun way. Essential information, such as applying for the National Identification Card replacement, could also be taught in a gamified way. Some service users might have been in the prisons or forensic psychiatry facilities for many years. Hence, new local places of interest will be foreign to them. This picture shows a new park called the Gardens by the Bay in Singapore. One of the difficulties that the therapists encounter is how to create such games in a platform that is accessible for people. For this particular game, there was difficulty in transferring it to a widely accessible online platform after it was created on a specialized software. Besides contextualization, we also need to personalize the games to the service user's demographic profile and age. This series of tablet games is to provide older adults with some form of cognitive stimulation. Hence, the goal is not to carry out intensive restoration of cognitive skills, but to engage them in a fun and personalized way. This game is called What Would You Like to Drink? Or Lim Simi in Chinese dialect. In this game, the user is supposed to follow instructions and do simple counting on everyday objects that are familiar to him or her. This is a game to sort dollar notes and coins. Again, this is a task that older adults may be familiar with. I will now move on to the use of online platforms to conduct group skills training. The COVID-19 pandemic has created opportunities for rehabilitation practitioners to explore the use of tele-rehabilitation. Occupational therapists at the Institute of Mental Health in Singapore started an online job exploration group using Zoom and are conducting a research study on this. In this group session, the service users shared their preferred work values. Those in red are the ones that they want to avoid, and those in green are the ones they feel they must adopt. Participating in groups via Zoom may be attractive to young service users who are tech-savvy and want their materials in soft copies. For those with anhedonia and negative symptoms of schizophrenia, Zoom sessions may be a way to start some engagement and connection. Otherwise, they may never turn up for a physical group intervention. It may also be an opportunity for us to learn a bit about their home environment. For example, do they have a noisy house? Do they feel they have some privacy, etc.? Even though the physical contact element is absent, social skills and norms can still be taught. The therapist can set rules on raising hands and turn-taking, to mute the microphones when not talking, to inform everyone via chat if a participant needs to walk away for a while, etc. Participants can also be engaged in smaller group discussions using breakout rooms. However, there are a few things to be considered when planning group sessions via Zoom. First, there may be service users with persecutory ideas or delusions who may be concerned about being watched by people outside the group, being recorded or photographed, etc. Hence, rules about everyone turning on their cameras, no recording, etc. are to be communicated. This is to enforce privacy and to make everyone feel safe. Secondly, some service users may not have a conducive home environment for online sessions. Brainstorming possible locations where they can have internet access and privacy may need to be done. Third, in a face-to-face group session, therapists can facilitate some physical contact activities to energize the group. This is harder to facilitate in a Zoom session, so therapists will need to be creative in the use of interactive tools such as polls, interesting videos, or even change their tone of voice and body language to hype up the group and keep everyone engaged. In summary, games can be used constructively for functional training by simulating tasks meaningful for the service user. Studies have also shown the effectiveness of games in cognitive rehabilitation, where functional gains are more apparent when therapists use a strategy learning approach. Very importantly, games should not be used in silo, but rather as part of a comprehensive psychosocial rehabilitation program, with clear framework for transfer of learning to daily life. Lastly, the use of online platforms for conducting group sessions is still at its infancy stage, with clinicians now embarking on research to study its effectiveness. There may be potential of reaching out to more mental health service users if we provide this online alternative. However, careful planning and consideration need to be taken in order to provide a safe and conducive virtual environment for service users to achieve their group goals. With that, I end my presentation, and these are my references. Thank you for your attention, and feel free to ask questions.
Good afternoon. Welcome back, everybody. Now it's my pleasure to introduce Professor Marianne Farkas. She's a professor of psychiatry at the Center for Psychiatric Rehabilitation in Boston University. She has co-authored and wrote several articles and books, and she's very active in the field of mental health education. Please welcome Professor Marianne Farkas.
Good afternoon, ladies and gentlemen. Excuse me. My name is Marianne Farkas, and I'm the Director of Knowledge Translation at the Center for Psychiatric Rehabilitation. I've spent my career trying to help develop innovations and then work to implement them in regular services. The Center for Psychiatric Rehabilitation was established in 1979 to develop new knowledge about working with individuals with serious psychiatric disabilities and then translating that new knowledge into usable tools for a range of stakeholders, administrators, providers, family members, people with lived experience, and their friends. So I'm going to present to you what we have found relative to the topic, when training is not enough, implementing evidence-based practices. The university policy is not permitting travel due to the Omicron variant, which is why I am speaking to you from my house. I loved being in Abu Dhabi, which I visited about 4 years ago, rather than sitting here in Boston, USA, where it is a cool 1 degree Celsius, and this morning we had snow. So I want to begin by thanking the organizers of the WAPR Congress for giving me the opportunity to speak to you this afternoon about the challenges involved in getting evidence-based practices into the field. First, I will talk a bit about our historical methods of doing that. Then I will discuss why our typical solutions don't work. I'll present a bit about an approach that we have been developing at the Center for Psychiatric Rehabilitation to overcome some of these problems. And lastly, I will talk about what we've learned so far in our field trial of this approach. Give me a minute here. Yes. I have no disclosures. The learning objectives are in the abstract. So I'll go right to the meat of it. There has been a profusion of new interventions and approaches in mental health and rehabilitation. Programs that help people in mental health recovery learn new skills, manage their symptoms, connect with others in recovery, and develop their own evidence-based practices, etc. However, the speed of these developments is not matched by the speed with which these new practices are being put to use in the field. Let me just give you one example. Let's take recovery, which seeks to help people achieve meaningful lives with their full partnership. The first known peer-run agency was, in Spain, focused on hospitality and well-being instead of pathology and deficits. And that was in 1536. Hospital run by patients. 450 years later, a series of longitudinal studies demonstrated that in fact people with schizophrenia, in the case of the studies, did in fact recover and well-being was possible. It took another 20 years after that for recovery to become the national policy in several countries, and we are still working on integrating a recovery orientation into the mental health field. In mental health and rehabilitation, we're looking to positively impact the lives of people who are challenged by their mental health condition. We develop and test our ideas as we create interventions that are backed up with evidence about their efficacy in helping people with disabilities fulfill their potential. Unfortunately, it typically takes 20 to 25 years from the time we prove that they are effective to the time they become available to the people who could benefit from them. In today's world, with all rapid advancements in technology, some of these interventions that we develop might not even be relevant by the time they are implemented. We need to find a way to bridge this gap and shorten the time it takes to bring helpful tools and interventions into the field. So the movement from evidence to practice and the slow uptake of these interventions tends to be because we focus mainly on the workforce alone as the agents of change. Not that they're not important, but we used to focus on changing the skills of the workforce as the primary method of implementation. What we used to think was that if we trained the workers, then we would have evidence-based practices in daily practice. Now, globally, we learned that training is a limited solution and often ineffective in integrating those evidence-based practices. Why? Getting enough trained people into mental health services is a global issue. Even though there were vast differences among countries, there are significant problems that exist with recruitment, training, and performance in mental health and rehabilitation. In addition, 85% of the population live in low and middle income countries where there is a serious lack of workers in mental health, trained or otherwise. And many who are hired seem to carry stigmatizing attitudes and continue to believe that paternalism, coercion, and low expectations are the norm. People with lived experience who do not receive competency-based training often themselves feel co-opted and improperly used in mental health agencies. The training that does exist is hard to scale up, and most training is not competency-based. Trainings in mental health services used to be piled on top of each other and viewed as a day off work. They usually consisted of a day or 2-day workshops. If the providers in an agency enjoyed the training they attended, their enthusiasm sparked others to try it when they returned to their agency. Once that enthusiasm waned, however, daily practice issues and challenges arose, and the new practice died out or the trainee left the agency. That was, and still is in many places, common practice. The second reason that short-term training did not translate into more effective practices is that study after study tells us that we forget what we learned in 4 weeks. If there is sufficient repetition, we may remember some more information, but even then, there is a decline. So for a long time, we were confused in our expectations of what training could do and its outcomes. We wanted workers to develop skills in the new evidence-based practices, but to develop it while using the least intense and least costly training available, which is exposure level training. We've developed a continuum of training intensities that I call the 4 E's. And the first of those 4 E's is exposure training, which is what most training is. Usually an hour webinar or an hour presentation where the goal is to increase awareness of new concepts and new information. Experience training focuses on increasing understanding and developing positive attitudes about the new information. It might include role plays and scenarios, and this is what most 1-day workshops or 2-day workshops are focused on. Expertise training, which focuses on increasing the ability to perform skills and competencies, is usually an intensive training program that requires practice with real clients, feedback, and supervision in order for those competencies to exist. And the last of the 4 E's is what I call embedding training. And this is the kind of training that integrates the new skills into daily practice in an organization and helps the providers to work on modifying the infrastructure of the agency in order to accommodate the new skills as well as to support their delivery. In general, studies show that there is a lack of available competency-based training designed to support daily practice. And this result has been found pretty much consistently since it was published in 2003. Often there's a lack of financial resources to invest in the intensive PSR training that produces expertise, or the competencies that serve clients, even in high-income countries such as the US and Canada. Training for sustainability is organized differently from exposure or experience level training. The delivery of skills can imply doing things differently in the agency, as I mentioned, and these changes need to be addressed directly in order to embed the practice. So sustainable practice is supported by leadership, supervisory structures, strategic plans, policies, procedures, agency and client record keeping. Organizations, for example, that have procedures in which goals are set after an assessment period may need to change their procedures, activities, and accompanying progress records to allow goals about roles to be set before assessments as PSR techniques dictate. If this does not occur, then no matter how expert the practitioner, the person will not deliver their new competency because it doesn't fit the structure they are in, and there is no reinforcement from the agency for them to do so. Systematic implementation produces sustainable practice. The problem, however, is that despite even expertise level training, there is limited access to effective or promising practices. Incremental implementation requires decades to change practice because that implementation of new evidence-based practices is usually done one agency at a time. Excuse me, I haven't had my morning coffee. So we at the Center for Psychiatric Rehabilitation have begun to work on the notion of scaling up evidence-based practices. And what is scaling up? It's an increase in the coverage of interventions that have been tested in pilot and experimental projects to benefit more people. And what do we mean by an increase in coverage? We mean extending the geographical reach of an intervention so that it can benefit a larger number of people. We conducted a cross-field comprehensive scoping review of large-scale implementation. We reviewed the literature in public health, education, mental health, and business in order to try to analyze common themes and items identified as improving or hindering large-scale implementation. And some of the levers that were identified include the attributes of the program being scaled up. That is, how complex is the new intervention? How resource intensive is it? How ready is the intervention itself for dissemination? So, for example, supported employment, which is a predominant PSR intervention these days, requires dedicated staff, collaboration between clinical services and vocational services. It is, when it was published in the mid-90s, it had the beginnings of readiness for dissemination. There was a manual to teach people how to do supported employment, but the manual for implementation had not yet been developed. There were no tools to support the actual delivery of the intervention. And that made it take almost 25 years to actually implement on a broad scale. So the attributes of the evidence-based practice is critical. The attributes of the people doing the implementation makes a difference. For example, the readiness for change among staff. How resistant are they to the introduction of something new? The readiness for change among the leaders of the organization. The match between the intervention and the values of the agency. The resources that the implementers have at their disposal. The funding available to introduce and start up and sustain the intervention, and the baseline knowledge and skills of both the staff and the leaders with respect not only to the evidence-based practice being introduced, but also to the process of implementation and change. The third lever of large-scale implementation is chosen delivery strategies, or the strategies that you choose in order to make implementation happen. So, for example, do you use training first to make a difference across stakeholders? Do you start with consultation? Do you engage different layers of stakeholders in the process? If you choose training before you've assessed the readiness or developed readiness of the organization, the training will not hold and implementation will be delayed. And fourth lever of large-scale implementation is the attributes of the adopting community, or the socio-political context in which the new intervention is being adopted. So in our situation these days, of course, COVID-19 is the easiest context to point to. The advent of the pandemic closed services, changed them to remote delivery in a matter of weeks. And that made the medical, social, and political context very difficult for the implementation of new evidence-based practices. Everything was in chaos, and the focus of attention was on the political, in our case, Trump, upheaval, and the funding and health issues that went along with it. So the attributes of the community that is adopting the evidence-based practice and their socio-political context plays a great role in whether or not you can do large-scale implementation. So as I've already said, fiscal policies, contracting, regulatory policies, public support, and political support for sustainability. So the implementation of interventions on any scale is difficult. Many challenges stand in the way of reaching positive implementation outcomes. Barriers and facilitators in and across attributes of implementation, the ones that we've discussed, interact in various ways to influence the effectiveness of your implementation. And for large-scale implementation, that is implementation across a geographic unit, a county, a province, a state, it makes it even more complicated. And yet, scaling up is critical to the introduction of evidence-based practices if clients are actually, users are actually to benefit from the innovations we've developed. In the US, about 3 or 4 years ago, they did a study of the number of people who had access to supported employment, even though it had been in the field for almost 25 years. And only 2% of service users who could benefit from supported employment actually had access to it. And again, that is why large-scale implementation is so critical. So if it's so critical, why is it so rarely planned for or done? Implementation efforts take 2 to 5 years in one agency. No politician will support or fund change that takes longer than his or her term in office. And mental health administrators are no different. They are really adverse to long-term change. And yet we know that while you can change the way people speak about something, you can change their language about it in about 6 months, it really takes 2 to 5 years for sustainable change to happen. Because people only change at the pace that they can change at. And no matter what we do, this remains the average amount of time for the adoption of a new evidence-based practice to be integrated enough to be actually sustainable. Large-scale implementation can take even longer. And it's costly to build competencies along with creating the culture and commitment of stakeholders to integrate and sustain practice. Given these challenges, we developed an approach to large-scale implementation that takes the factors we've discussed into account and uses technology to make the process less costly and more efficient. Now, it would have been impossible previously to base a large-scale implementation plan on the use of technology. There was too much resistance in mental health and rehabilitation to the use of technology, and a lot of skepticism. Most people, including me, didn't go into mental health to be tech wizards. We want to be close to people. We want to interact with them, have an actual connection. So the idea that we would base everything on technological tools really was an anathema. However, the pandemic really changed this attitude, and it moved the field in a very short amount of time to accept technology tools as helpful, whether they were for providers or for service users alike of all ages. I am what is called a digital immigrant. That means I belong to an era of non-tech approaches, but I have had to learn how to make technology work for me in this new reality, as you can see, using the Zoom platform in order to speak to you today. Given this, it is possible to think through an implementation approach to try to cover a large sector of mental health services with new evidence-based practices using technology integrated into it from start to finish. Now I want to talk about the basic elements of what we call the integrated scaling approach. The comprehensive review of the literature that I mentioned before identified these elements as common to successful scaling up. And you will notice that they are not earth-shattering. They're nothing new that you wouldn't have thought of if you sat down and really thought through the issues at hand. But it confirms that comprehensive attention to these 5 elements are important to the success of being able to spread evidence-based practices across a geographic area. So the first is increasing the demand for that evidence-based practice. If you do not systematically attend to the demand, new interventions that are needed may be introduced into the system, but not wanted, either by the providers, service users, families, or others. People don't like change. And if you don't have a marketing campaign of some kind, most people would rather keep the tools they have than try to adopt new tools. And the drug companies have really learned this lesson very well. When they introduce a new drug into the field, they go on a high-stakes marketing campaign to the providers who prescribe the medication, as well as directly to the users of that medication to get them to go and ask for the medication from their providers. And we sought to learn from that using a marketing campaign for new evidence-based practices. The elements 2 to 5 require strategies of educational, organizational psychology, and elements of economic, sociology, political science, and computer science. So a complex background in order to what? To increase the capacity of providers on a large scale, to increase organizational capacity, as I mentioned before. We can't focus on providers alone. To increase systems capacity and the support for the innovation. And then using the technological tools that I mentioned before. In other words, the real implementation of EBPs requires strategies that are way beyond just training. Here are some examples of what I'm talking about. Focusing on the increase of demand that I mentioned. So for the project that I am referring to, we developed an online marketing toolkit that could be used flexibly by agencies depending on their situation and their particular local context, that included social media posts, podcasts, posters, and flyers electronically in order to market the particular, evidence-based practice. In our field trial, we're using the evidence-based practice called Thinking Skills for Work in order to learn about large-scale implementation. And this is an example of a post that we put on posters that agencies could put on their walls. Of course, at the time we created it, we didn't realize agencies would be remote, so they put it on their website. They used it on Instagram, Facebook. They used a Twitter version of this, directed to people with mental health conditions, specifically their families and friends. And the message we sent was basically, work is possible and we can help. So this is an example of developing a marketing campaign and using available technology tools to make it diffuse into the field. Increasing provider capacity. As I've said before, developing new practice requires not only changing knowledge, but attitude and skills. And online training, is usually used just for knowledge and has a large drop-off in participation. So most online trainings have a lot more people who register for them than those who complete them. We created a self-paced online training for Thinking Skills for Work that was brief. It was usually 20 minutes per module. Actually, we said 20 to 45 minutes, but now we've cut down each module to 20 minutes because that appears to be the limit of people's attention span online. Created the modules with increased interactivities, discussion boards so that people could speak to each other, quizzes that required the learner to do something rather than just sit there. We increased the sensory shifting, meaning the variety of different ways the information was presented: audio examples, videos examples, scripted scenarios, and live client and practitioner excerpts. And we tried to address both intellectual and emotional responses to the material in the way that the modules were designed. So far in our field trial, we have a 75% completion rate of the self-paced course. So we believe we've learned something about how to organize self-paced online training. Provider capacity, as I mentioned before, also requires supervision, and remote learning is no different. It requires some face-to-face regular interaction, which we did through Zoom. It requires digital recording practice sessions with clients who are actually on the provider caseload. So the supervision could still be intensive, but we didn't have to travel to different sites to deliver the supervision, and we could still listen to exactly what had occurred in the client-practitioner interaction and provide real feedback, even though it was remote. People uploaded their session to a secure website, and as I said, we gave supervision to specific practices. So these technology tools reduce the amount of time a trainer, who was usually the expensive part of training, had to spend supervising a larger group of people. We also created an app for Thinking Skills for Work to promote learning. And the app is designed to bridge the gap of what people learn in the TSW online course and the step-by-step procedures necessary to do the practice of the EVP with a client. So this app contains checklists, worksheets, reminders of goal, etc. And the way in which it helped us to reduce the amount of time necessary for supervision was that usually supervision requires you to reteach people what they have learned in previous weeks because they've forgotten, and particularly would have forgotten in online training, because it provides the structure for the practice in real time. We increased program capacity. So we spent time where it was possible, and it was not always possible, to use existing software to help agencies restructure some of their practices to collect data as a regular part of their work in order to track progress on thinking skills for work. If agencies have IT professionals, they need to understand these implementation tools in order to be able to support the providers. If agencies don't have IT personnel, they have to contract with this kind of support or persuade funding bodies to provide such support, because the support is a critical element of any implementation that uses technology tools to increase its geographic reach. Increased system capacity. Technology was less important in changing the system's capacity to support thinking skills for work practice, because the state, like most states in the US, have their own electronic records, their own data collection methods, their own feedback loops, etc. So creating new ones using different tools made no sense. What we did instead was to add questions to their existing data collection methods, for example, about the enrollment in thinking skills for work in order to support sustained use. So simply asking providers how many clients are enrolled in thinking skills this month cemented the message for agencies that the state was interested in their using this intervention and would ask about it in later performance reviews of their contracts. So the system capacity changes can include changes in regulations. Thinking skills for work did not require that. Changing in funding procedures, which we are still working on. Changing in evaluation and performance measures, which we did, as I mentioned before, by adding questions to their data collection method. And changes in reporting, reporting progress and reporting changes in agency outcomes. In addition to all this, we had to use an array of communication tools to increase the program's congruence and system support for the new practice. We used GoToWebinar or Zoom platforms like this one to allow visual contact, to be able to pick up on nonverbal cues, both in our training and our work with systems administrators, as well as to share documents in real time. The communication technology has become a major boon, as you know, to work of any kind, but in large-scale implementation, it is critical. There are so many different stakeholders involved in different geographic regions with different parts of the process at different times, but they still have to be involved and kept engaged. And without these tools, the process would collapse. So what have we learned about large-scale implementation to date? I mentioned that we are doing a field trial right now of the integrated scaling approach. Our current development project is in the state of Georgia. We tested the prototype of this approach in New Hampshire and then in Oregon, and now we are doing the actual field trial in Georgia. Georgia is a state that is both highly sophisticated, it has highly sophisticated urban areas like Atlanta and large counties of rural farming land. We were concerned about the technological divide. Would clients be able to access the internet and laptops or cell phones in order to get on Zoom meetings, etc.? What about the provider's level of sophistication and willingness to deal with a variety of tech tools, digital recorders, apps, project management, communication platforms, online training, secure websites, and all of that? Well, I'm not going to pretend that this was easy. It was a heavy lift. But we learned that it is possible, mostly because almost everything can be done through cell phones, through hotspots, even if there isn't good connectivity in a particular rural agency, and if you have a lot of IT support. Currently, we're integrating thinking skills for work in 12 sites at the same time across the state, involving 40 practitioners, 45 managers, and 2 funding bodies or state agencies, the Department of Mental Health and the Department of Vocational Rehabilitation. The most critical lessons we've learned here is that increasing provider capacity while increasing the program and system support is complex, especially during a pandemic. It's a nightmare, but it's necessary to make the change sustainable and feasible. So our experience mirrors that of the literature. Introducing technology does in fact help increase the reach of the program and can be done even in rural programs. And this was one of our major questions in our field trial. And third, using technology as the main channel through which our implementation strategies are delivered does require its own implementation plan, independent of the implementation of the intervention. So what do I mean by that? Because technology and the technology we used is complicated and not familiar for most providers and agencies, never mind service users and their families, we had to have a special plan for how to introduce each element of the technology, how to support people, how to give them a training period to be able to learn to use it so that they didn't give up in frustration. Sometimes they did get very frustrated and used a particular piece of technology less than we liked, but we learned which kinds of tools out of the array that we introduced them to were adopted most easily and which ones they had difficulty with. Interestingly enough, the app was something that people had difficulty with. They felt that it slowed them down, and so they used it only some of the time. Pardon me. So we would never have been able to staff the implementation of 12 sites at once with in-person delivery. Both the personnel needed and the cost would have been prohibitive. And we know that instead of spending 2 to 3 years getting each agency up and running one after another, reaching maybe 3 or so a year, we can reach 12 at a time, at least so far. So now I want to summarize and close, and I'm not sure if we'll have time. We'll have a few minutes perhaps if you have any questions. Delivering mental health and rehabilitation services that make a difference to people with psychiatric disabilities is complex and has multifaceted challenges. If there is nothing that I have transmitted to you in this presentation, please understand this. It is complex and it has multifaceted challenges. However, evidence-based practices provide us with options to pursue. While training is absolutely critically important, it is insufficient to integrate evidence-based practices into services. And scaling up evidence-based practices by increasing the demand for the new intervention, increasing the provider's capacity to deliver it, increasing the agency or program and the system's capacity to support it, using technology is one strand of the solution. So thank you very much for your attention. If you have any questions.
Thank you very much. Colleagues, welcome to this symposium. This session is really looking at the impact of COVID-19 in different countries. And we have, for this session, selected a few countries because the session was generated and recommended by Professor Michael Stark to look at the impact of COVID-19 in different countries. So we'll have an understanding of what happened in relation to COVID in India, in Kenya, and a perspective about issues related to COVID-19 from Professor Michael Stark in Germany. He's not going to give an overall perspective because he feels that may be covered. And I have sent a video looking at the perspective of COVID-19 in South Africa. But I would really be happy if we can start now to play the video from Professor Michael Stark. Michael, what is the title of your video?
The title is that I was looking at the scientific problems that show with the COVID-19 fatigue problems, because psychiatrists are suddenly confronted with the fatigue problem, which is close to the psychosomatic illness, which is and I have been working on that to discriminate the long COVID fatigue, how we can differentiate neurological from psychiatric origin of fatigue. That's the title of my presentation.
Thank you. I think that's a very good angle to approach COVID-19. So could you please play the video submitted by Professor Michael Stark?
Good afternoon, ladies and gentlemen, dear colleagues. I'm so sorry that I cannot attend the conference in person at Abu Dhabi, but Corona has put up lots of restrictions. Today I want to tell you about the new challenges Corona has put up for psychiatry. Corona has not only caused major problems in the psychiatric service system, but also led to new research topics. So long COVID has opened a new challenge for psychiatry to deal with the fatigue syndrome, which is a substantial loss of cognitive and muscular power. What is fatigue like? Fatigue is also observed in various psychiatric diagnostic entities, like depression, like psychosomatic disorders, like neurasthenia, and others. The accompanying somatic complaints led us to think of it as a functional disorder, but it also resembles in symptomatology and pathology the chronic fatigue syndrome. There, in most cases, a virus such as Epstein-Barr is responsible. Here, Corona. So it seems to be the same pathology. We see alarming numbers. Many international studies see 50 until 60 or 70% of the long COVID symptoms as predominant in fatigue. So the assumption is that, for example, the chronic fatigue patients will double within 1 year. How can we discriminate virus-driven fatigue, so to speak, from fatigue accompanying psychiatric illnesses? We have to look at the neurobiological basics, which I will get into in this presentation. The basis of this assumption is to look at the basic saber-tooth tiger reflex, which I tell my patients, the stress reaction, a basic instinct to save oneself from danger. This is our old enemy when we climb down from the trees. The amygdala is our center for hazard detection, and if the amygdala sees danger, it controls in the limbic system our life library, whether we have met these kind of situations in our life already. And if so, there will be a stress response initiated through our autonomic nerve system, fight or flight. What we do, we run away, or we used to run away. The hippocampus registers movement and exhaustion of the muscles and has a calming effect of the stress response. Also, our frontal lobe, our mind, realized that we are in safer place in the cave, which also lowers and disrupts the stress response. But the world today is changing. The same automatic stress response, but now unconscious and chronic, will work in our work environment with toxic exposition and with viruses. Because my hypothesis is our regulatory center, amygdala, limbic system, hypothalamus, has not only an external perception, what stresses, physical or psychological, am I exposed to? These are quite accessible to consciousness. But I think our system has also an internal perception, which when I leave, which acts when I leave homeostasis, that also triggers then fight or flight reactions. So if we look at these kind of assumptions, we have we've found in our chronic fatigue patients predisposing factors, genetics, exogenous stressors like viruses, bacteria, toxins, trauma, and acute mental stress. That is answered by amygdala arousal. And the amygdala leads to sympathetic activation. Chronic symptomatic activation leads to immune disorders, HPA disorders, and oxidative stress. That leads to adrenocortical disorders, latent infection reactivation, allergic sensitivities, mitochondriopathy, and gut microbiome problems. So the amygdala find that out through internal perception, and this leads to a chronic sensitization, and here we have the vicious cycle that goes around and around. What happens? The model of stress staircase explains that. We don't have the normal change between tension and relaxation, but we increase our stress level until finally we have the symptoms we observe in our patients. The normal amygdala reaction, the sympathetic nervous system, here we have the focus on the danger leads to cognitive finally overload if it's chronically. Muscular apparatus is optimized, but that leads then to pain syndromes and breathing problems, blood pressure, dizziness, weight problems, and skin problems. The chronically reduced parasympathetic nervous system functioning is much worse. It leads to troubled sleep, unrefreshing sleep, irritable bowel syndrome, metabolic disorders, menstrual problems, loss of libido, and deprived specific immune systems, structural disorders, and loss of orientation. And then it might be open for attacks of viruses. The chronic fatigue syndrome is diagnosed with the Canadian criteria. These requirements of observations is worsening condition after exertion and exhaustion, sleep disorders, pain, neurological cognitive manifestations, autonomous neuroendocrine and immunological manifestations are required at the same time to be observed. And the illness has existed for at least 6 months. Lots of the post-COVID patients now who develop fatigue and now fulfill these diagnostic criteria for chronic fatigue syndrome. If we look at the differences between fatigue, which we observe, for example, with depression, depression occurs rarely in a temporal context with an infection. A change in mood is necessary condition for a diagnosis. In chronic fatigue, exhaustion is a necessary criterion. Depression is usually not associated with significant pain symptoms other than chronic fatigue patients. In depression is normally no association with autonomic symptoms, and orthostatic intolerance, tachycardia, and other autonomic dysfunctions are required as a diagnostic criterion for chronic fatigue patients. And with depression, we see normally no association with immunological symptoms, which are required as a diagnostic criteria for chronic fatigue syndrome. Also, in depression, we find no connections with thermostatic instability. Exhaustion and mood gets better with physical activity. In contrast, exhaustion is aggravated through mental and physical strain in chronic fatigue patients. In chronic fatigue patients, we find a decrease in positive feelings, whereas depression is described as an increase in negative feelings, apathy, hopelessness, suicidal thoughts. Children seem to have a better prognosis than adults in chronic fatigue other than in depression, and the cortisol levels are low in fatigue, whereas cortisol levels are increased in depression. So there we have some differences in diagnostic criteria. But is fatigue measurable? In the literature we find possible markers: chronic regulatory disorder of the autonomic nervous system, HRV, heart rate variability measurement with change in position, hand grip manometer measurements, power declines in repeated measurements, and 2 times spiroergometry, the power drops. There's a power drop of more than 10% in the second measurement. Here we did that HRV diagnosis. Here is a woman, 54 years, with an HRV test, and you see the red line is around the 0 degree, and the parasympathetic system also around meanders around the 0 degree. She is a healthy person. And a woman in the same age, chronic fatigue syndrome since 2013, she has the red line of sympathetic activity is far above the 0 level, and the parasympathetic is far below the 0 line. So that discriminates our patients, of CFS patients, from normal patients and solely depressed patients. Another graph shows the differences between lying down and standing up. The activity of the sympathetic nerve system is in both positions, it's high, and the parasympathetic activity is low, and it doesn't increase in the resting and the lying down position. That is typical for fatigue. We have another chronotropic response. We can the computer find that out, and here this patient has a chronic reaction of 0.78, and 0.64 is still the normal measure. We have therapy approaches based on the chronic stress hypothesis we use in our institute. This is body therapy, method to relax the sympathetic overactivity and strengthen the parasympathetic activities, and a psychotherapeutic method to deal competently with stress and training in a relaxation method. Here we have a patient that ran 1 year through our therapy. Here you can see at the beginning there were no activity in parasympathetic function. Here we have, after 1 year, we have parasympathetic activity and a lowered sympathetic activity while he was resting. So this is the normal way it should be. Thank you for your attention. I hope I could draw your attention to some of the critical issues we are confronted since Corona has risen. And I hope you have a good trip home. Bye-bye.
I just wanted to ask Professor Stark, just in 1 minute, if he has anything to add to the video. Is there anything you want to add to the video that we've just seen? The scientific approach, this analysis?
Yeah, okay. Okay.
We just have 1 minute for that.
All right. No. If you have any question to that, you can ask me. But I think it's. I brought it up. I took the chance to bring it up at this great World Congress because I know that the World Association of Psychosocial Rehabilitation is has a broad vision of psychiatry and tries to look at very interesting aspects, and that's why I brought it up, because I think it's for a psychiatrist it's a new challenge to be confronted with these kind of patients, because all the internal medicine doctors, they send these patients to psychiatrists because they cannot help them, and they think, okay, they're only tired and maybe they're only depressed, and go to a psychiatrist and he will help you, and the psychiatrist gives them psychopharmacotherapy and it doesn't work, or let them run and do physical activity and they get worse. So this is a real challenge for us psychiatrists.
Thank you very much. So this is work in progress, something that from the psychosocial rehabilitation perspective, we should continue to explore. So let's move on to the next speaker, that is myself. Just an overview of the struggles we went through in dealing with COVID-19 in South Africa. So I have a video that's going to be played. It's shorter than your presentation, Michael, but hopefully it will be similar to some aspects of the issues in India and also in Kenya. Thank you. Thank you very much for asking me to reflect on our experience in South Africa on the neuropsychiatric effects of COVID-19. My name is Professor Solomon Watamani. I'm a practicing psychiatrist in South Africa, and I'm the chairperson of the Medical and Dental Board of the Health Professions Council of South Africa. I do not have anything to declare. I confirm that I prepared this presentation on my own. In the early stage of COVID-19 in South Africa, there was just rumblings of a serious illness from China that was going to affect the whole world. There was no real concern among African people and in South Africa and also in other African countries, because they thought this was a disease that was Asian in origin and it was not an African disease. However, late March to early April 2020, when first cases were detected, people started getting concerned. Number of infections were still low, but few people started dying, sudden deaths after admission to hospital. There was therefore general anxiety amongst most people, particularly educated ones, as deaths were registered. Government responded very quickly in collaboration with guidance from the World Health Organization
and other countries such as Italy, China, and the United States, the president introduced level 5 lockdown, and a night curfew was imposed such that people could only travel up to 10 p.m., but no travel was allowed between 10 p.m. and 5 a.m. Restaurants were closed except for takeaway areas where possible. Flights in and out of South Africa were cancelled. This therefore means suddenly there was a stop in terms of normal life in the country. Alcohol and cigarette sales were banned with moderate access and moderation later. World Health Organization regulations were implemented, and this included social distancing, washing of hands, and sanitizing, wearing of masks. This was initially not mandatory, but later it was legally enforced, particularly in public spaces and in shopping complexes. Movement from one province to the other was curtailed, except with permits that were given by government. And we had to specify what the purpose of travel was. There was recommendation that people, where possible, should work from home. Taxis and other transportation means were limited to a certain number of passengers per vehicle. There was obviously a very, very strong community response to this because people suddenly felt that there was curtailment of freedom of movement and association. So they were very angry. There was panic when number of deaths increased. There was also fear of going to hospital, as these were seen as places where people go to die. At this stage, the whole world was struggling with a sudden surge of very sick people. There was a demand for more hospital beds and sudden increase in demand for oxygen supply in various forms. There was no clear treatment protocol in place for this illness that people and the practitioners in the front line did not understand. But these protocols were obviously developed later. A number of businesses were shut down and joblessness suddenly increased. Government introduced a relief grant, very little, and for most affected businesses and individuals. Government-sponsored personal protective equipment was put in place and introduced, but it was undermined by various scams that delivered cheaper and non-effective ones. And of course, this led to a number of deaths of frontline practitioners, such as doctors and nurses. Schools were closed and teachers and pupils were afraid to go back to school because the deaths were increasing in the country. So parents were asked to assist their children with learning at home. There were specific clinical interventions, including increased testing of people in all provinces, particularly around the epicenters that were identified from one province to the other. Laboratory tests were fine-tuned, and these were explained to citizens so that there should be no confusion. However, false positives and false negatives confounded the findings, but these were cleared with time. All deaths were checked for COVID-19, and when it was present, these deaths were notifiable so that we can get accurate statistics of people who died from COVID-19. Also, all comorbidities were documented, including diabetes, hypertension, other chronic illnesses that were there before COVID-19. There was a restriction in gatherings, for instance, limitations in terms of number of people who can go to church, who can be at celebrations such as weddings, and who can attend funerals. People are encouraged to present early for testing and go to hospitals early so that any form of intervention can at least reduce the severity of the illness and help people to recover. But despite concerted interventions, deaths continue to increase. So there were some clinical observations about these deaths, namely that most people died shortly after diagnosis and even soon after admission to hospital. There was also fear of being labeled COVID-19 positive, leading to late interventions. This means that there was also psychological stigma at being identified as being COVID-19. But this was obviously allayed by more communication from government channels. Mainly persons over the age of 60 were dying in the initial phase, but as the pandemic worsened, even younger people and much older people in the 70s, 80s were dying. Comorbidities such as diabetes, hypertension, obesity, HIV/AIDS, and other physical illnesses such as cancer were seen to accelerate the rate of death. And people were told to be careful if they have these illnesses and not to expose themselves to infection without any of the protections that were advised by WHO. Poverty and malnutrition was also implicated, and including underlying cardiovascular diseases. This was very important because most frontline workers had not checked for all these diseases. Then they were dying, and it was also noticed that when a frontline worker like a doctor died, a relative or a friend would also die. Government also included more interventions by establishing a national communication strategy, a central command that was led by the Minister of Health. Weekly messages and updates from the president were introduced. Efforts were made to dispel fake news and encourage citizens to behave responsibly. And this communication highlighted early signs and symptoms that may be related to being COVID-19 positive, such as dry cough, fatigue, weakness, loss of appetite, and in some cases, confusion and panic attacks, headaches, and other unexplainable physical symptoms occurring suddenly, including shortness of breath, sweating and dehydration, and later loss of taste and smell. The observed mental health effects include the following: a sudden increase in patients with acute anxiety disorders because of the underlying fear of death of themselves personally and of their friends or relatives. Severe anxiety and depression before and after admission to hospital was noticed. All this above was made worse by uncertainty of when the pandemic will end. There was also a problem of loss of jobs, fear of dying, death of friends, death of colleagues and relatives. This added more stress to individual people who were affected. The suddenness of deaths and apparent absence of any effective medical treatments was also a concern. Researchers noted increase in relapses among mentally ill patients who were stable before, and some of these relapses were due to fear of going to clinics and hospitals for their usual treatment, so they were not getting their usual treatment. But others were due to the stress related to fear brought about by COVID-19 spread. It was also noticed that substance abuse, mainly use of alcohol, increased, and in young adults, use of substances such as cannabis and opioids to relieve stress and pain increased. A few patients presented with delirium as a first sign, or even acute psychosis in the early stage of illness. And later on, a number of people were diagnosed with post-traumatic stress disorder, which of course cleared up a little bit after interventions. There were also specific neurological effects, and this seemed to occur because of direct entry of the virus into the brain, causing direct injury to the brain. And this may include the following based on numerous studies and clinical observations in South Africa. Firstly, delirium, which confusion, disorientation in the early stage of the illness or at the height of the illness, encephalitis and meningitis, which was late in the illness and sometimes manageable. There was also very rare but observed epilepsy and seizures at any stage, but even if it was rare, it was noticed in some young and older people. In severe forms, some patients presented dementia and severe cognitive dysfunction with memory loss, failure to understand their surroundings, failure to enter into normal conversation. And those who developed strokes, though there were few, also had major depressive disorder. Some patients had transient ischemic episodes with fainting attacks and minor seizures. And there was also, and this was a persistent and commonly reported problem, severe and acute fatigue. This will be chronic in the later stage after hospitalization. At post-hospitalization, a number of patients presented weakness, general or specific, due to direct effect and damage to the nerve. And there was also lingering loss of taste and smell. In some patients, it took much longer to recover. And obviously, in alignment with mental illnesses, post-traumatic stress disorder was also diagnosed amongst those patients with mental illnesses. The overall response and observations were that hospitals and clinics were suddenly overburdened until practitioners understood the nature of the pandemic. More people became aware of the severity of the pandemic and asked for help earlier. The second and third waves of the pandemic were less severe, but deaths still occurred. Introduction of vaccines improved matters with fewer severely ill people. So the healthcare facilities were more prepared and rearranged to be ready for the pandemic. And when vaccination was introduced, the post-vaccination mental and neurological symptoms persisted in a small percentage, the so-called long COVID, which included extreme fatigue, weakness, anxiety, and depression. Although at almost 90,000 deaths in South Africa, for a population of 60 million, the situation in South Africa has greatly improved. And South Africa is now at the lowest form of lockdown, which is lockdown 1, very little in terms of restrictions, and more businesses are opening and starting to operate properly. But there is still a lingering fear of the fourth wave, and also a fear of more new variants of the illness coming up. However, the country is more prepared to deal with those variants. In conclusion, this is still work in progress, but there is hope that the pandemic will not be as destructive as in the early stages. Mental health services are functional now, and hospitals are adjusting to the new normal. The drive to vaccinate more people and develop herd immunity continues in full force, and this is led by the President of the country. I want to thank you for your attention. Thank you for your attention, and without waste of time, we'll move on to Dr. Monique Mucheru from Kenya to give us a perspective of how they dealt with COVID-19 or what they're still doing with COVID-19 in Kenya. Monique, I don't know whether you have slides to share or you just speak.
Good evening, all of you, Abu Dhabi. I'm presenting from my hotel room this evening. I'm still waiting for my green pass, but I'm happy to be here and I'm happy to present about the COVID situation in Kenya. Thank you, my previous presenters, for giving an introduction. The picture is quite similar in Kenya, just like South Africa. And I'm going to start by outlining my presentation. First, I'll talk about the background. I'll talk about the structure of mental health services in Kenya pre-COVID. Then I'll follow it with the mental health services during COVID. Now, the background, I'll tell you about our geographical location, how our healthcare system is structured, and how...
Please move the slides, Monique. You're not moving them. The slides are not moving.
Maybe I could, on my end, they are moving. Could John assist me?
Okay.
Sorry. Apologies for that technical hitch. I was talking about our geographical location, our healthcare system, and the effects of the pandemic on our healthcare system. Next slide, please. So we are located in the eastern part of Africa, in green, and the structure of our government is federal government. Health is a devolved function. We have 47 counties. So when I talk about the healthcare system pre-COVID, the counties had already started preparing themselves for the pandemic. Immediately, the first case was announced in Kenya, and each county was supposed to develop their own COVID-19 strategy to deal with the pandemic. Then I need to mention that we have both private facilities and public facilities in Kenya, and the mode of payment is out of pocket. So we do not have free healthcare services in our country, and I'll explain how that made it more complicated. Then now the levels of healthcare, when it comes to the government, we start from the community level, which is level 1. Then we go to the dispensaries. Level 3 is the sub-county facilities. Level 4 is the county referral hospitals. Then we have bigger hospitals, which are private, which are also level 5. And then there are the national teaching and referral hospitals that are level 6. Next slide. So ours started like the South African story, where we had one case, the first case on the 13th of March, 2020. And immediately schools were closed, starting from the primary schools, continuing to the colleges, the high schools, the universities. Then public gatherings were banned. So suddenly people who had weddings had to cancel. Funerals were also, I mean, they had to be regulated. And initially funerals were conducted by healthcare staff. The relatives were not allowed to be part of the send-off for the loved one. So then about 2 weeks later, Nairobi, which is the capital of the country, was locked in terms of you couldn't leave or enter. So then what happened was anybody who had traveled up country to do something, or somebody, a spouse who had gone to do some work outside the county, was suddenly locked. Some mothers had gone for training, then their families lived in Nairobi, they couldn't come back to their children. And it actually caused a lot of problems. Then there was a dusk to dawn curfew, which lasted about 19 months. And to enforce this curfew, initially it started between 7 p.m. and 5 a.m. in the morning. So then to make sure people were in their houses by 7 p.m., then people had to leave their workplaces by at least 3 p.m. And most of the facilities like banks, any public facilities had to close early, so that, including supermarkets. We have supermarkets that ran 24 hours. Suddenly they were closed and they could only open between 8 and 3 o'clock. So there was difficulty sourcing for food. There was difficulty sourcing for transport, because even your fruit vendor had to close up very early, because unfortunately a bit of force was used to impose the curfew by our law enforcers. So then most people were living in fear, because you don't know when the next beating is going to be from the law enforcers. So then that is what happened initially. Then the curfew extended from March 2020, and it was only lifted the other day on our Heroes Day, which is called Mashujaa Day. It would be announced by the president. All these measures would be imposed, or rather would be addressed during a presidential address. So everybody used to wait for this address every so often. So then it could be such that its curfew has been extended for the next 60 days. So then people would feel quite wary, they got quite stressed, because then they couldn't work the way they couldn't travel as should. Then at some point, there were 5 counties that were locked, Nairobi and some surrounding counties. So people from the other counties could not access any services, whether medical or otherwise, just like they used to before. Then now there was the mandatory use of the face mask, and there is a jail term of 6 months and at least $200 fine if you're found not wearing a face mask. Then the worst of it was how the isolation, contact tracing, and mandatory quarantine was done. First and foremost, if you returned home before they closed the borders, or the borders of the country were closed, you were shipped in a bus, taken to a government facility where you were tested for COVID-19, and you could remain there waiting for your COVID results for several days. After that, then you'd be quarantined for 14 days. Then after that, it extended. At some point, the results would take so long for the people who are in quarantine to get their results. So initially there was mandatory quarantine. Then once they diagnosed a case, then there was contact tracing. And the contact tracing, the health officers would come at night in an ambulance, dressed in full gear. They would come in head covers, face shields, the gowns, and they would take the patient by force to an isolation center, and everybody else who had come into contact with them who needed to be quarantined at that time. But with time, there were regulations that were developed for home isolation, which then now made it made it easier. The next slide. So then I want to show you a sample of the statistics we would get, or we continue to get, from the government, from the Ministry of Health on a daily basis. The slide on the left is about the vaccination status. So it is broken down on a daily basis. It is given on TV, national TV, all TV stations. And then it's also, it's posted on the Twitter handle, the Instagram page, the Facebook page of the Ministry of Health. Now, the one on the right is what we started with. So people would wait in anticipation to find out how many new cases do we have? What was the sample size? What is the positivity rate, and how many people had died? And this is that's the latest of 6th December. Next slide. Then now, about vaccination drives, it has become mandatory for every Kenyan citizen or anyone living in the country to get vaccinated. And we have a deadline of 21st December, so that anybody who will not have been vaccinated by 21st December will not be able to access government services. They'll not be able to go to any government office. They will not be able to enter public transport, whether it's by road, rail, domestic flights. So it's now mandatory that people get vaccinated. Then on the left, that's the slide on the left, shows the various counties and the percentages of the people who've been fully vaccinated. Then there's also a presentation of the COVID update, new cases per county. So they highlight the cases, and then after that they put it in they put it in social media, print media, and also TV. Next slide. Now, there were specific measures that were meant to cushion the Kenyans or the people living in the country. And first of all, there was a COVID-19 fund that was set up. This was to raise money to deal with the pandemic. And also, it was to ensure that vulnerable households had money transfer. We have money transfer services by M-Pesa, and other money transfer modalities are used to transfer money at a fee. So then the government would get the mobile number of the head of the household, and money would be transferred every month. Then for every employee, pay as you earn was reduced to 25% from the usual 30% to cushion the citizens. And then mobile money transfer services were also waived, so that if you are sending a small amount of money, up to $10, then you would pay nothing. But of late, it has been lifted, so people have started paying. Then these cashless transactions, debit cards, credit cards were encouraged, and the minister would encourage people not to use cash, otherwise, and that would be among the modes of transmission. So that's how the specific measures came about. Next. Then now, what about the healthcare system? Initially, anybody who developed symptoms, respiratory symptoms, first of all, there was a lot of stigma. If you coughed in a public means of transport, you would be asked to alight. nobody would want to travel with you. So then it was then recommended that if you're unwell, stay at home. If you have a cough, stay at home. If you're sneezing, stay at home. Then people would then rush to the health center or the health facility and find doctors or clinicians who are not who are not donned. They don't have the necessary COVID gear, and there were high infection rates. So then one of our mobile providers provided a toll-free 719. So then everybody could either message, you could message from your phone, you could call to say that you're having these symptoms, and they would now come with the ambulance for you. And then after that, if positive, you'd be admitted into an isolation center. Then at some point, like the first few cases, they would trace. The person came from the coast, traveled in a vehicle. There were 2 people in the vehicle. They then traveled, and all those people would be picked up. Then after that, they would then be taken to mandatory quarantine, and the one who is positive will be taken to an isolation center. Then,
may I ask you to summarize, because we need to at least give about 10 minutes to the President for his presentation.
I will, please. Then now the nursing staff in our institutions, some of them were taken to the airport and others were taken to run the quarantine centers. Then so there were longer shifts for staff, and owing to those curfew hours. Next. We needed psychological support, so we had a toll-free line. So most hospitals shut down. No appointments, no refills. The only people who were allowed into the hospital were after being triaged, and you would only be seen if you're an emergency. So then for admissions, you would have to be tested for COVID, which the insurance did not pay. You needed to pay cash. And then after that, for some staff who even contracted COVID and worked in COVID units, they had their salaries slashed for at least 3 months because, as my colleague said, patients refused to go to hospital. They were fearing to be diagnosed. Next, please. So then what? Next. So then when we talk about the practice statistics, this, in our own clinic, we started seeing online patients as seen there. Next. So we took up an online platform. Then there was licensing of telepsychiatry services by the Medical Practitioners and Dentists Council, free of charge. So we didn't have to pay anything. So it was easier for us to get a license, to call patients, to see them on video, and Zoom, WhatsApp video were very useful. The research on telepsychiatry calls for participation of ongoing researches they are going on. Then now, hospitals are embracing online ward rounds, grand rounds, meetings, examining students even at the university. Then now, good news is that at the mental hospital, the National Referral Hospital, there is plans to establish a telemental center, which is going to be giving telepsychiatry services throughout the country. Next. So then what we did were online consultations, prescriptions via email, WhatsApp, payment mode by money transfer, and delivery of the medication by courier services. We had community mental health services. We had separate wards admitting patients as opposed to those who had long-term stay. And then we have had 100% vaccination rates, especially for forensic patients at the National Teaching and Referral Hospital. Next. And thank you for your attention. And sorry, I forgot to say that my disclosures, I'm both in private practice and public service. So that is why you found my presentation had a bit of both. Thank you for your attention.
He doesn't speak too much, but he'll share a few slides with us. Over to you, Professor Morales.
Yeah. So straight away I'll get into the presentation. All friends, it's a great thing to be with Secretary General Soli. Now, most of the countries, it is almost similar situation, so I'm not going into that. Entire world was so-called united in controlling the pandemic is a doubtful thing. In Sanskrit, in Indian language, we say Vasudhaiva Kudumbakam. All world is one. India, the first case was reported in January 2020, first reported in Kerala state. 3 medical students, girls came from Wuhan. That is the way it came. And lockdown from March 25, all this was quite a little early lockdown. It was a complete lockdown. All health services affected. Persons with psychiatric illness are more affected. And the thing is that entire world stands still due to lockdown. Restricted travel, no public transportation, healthcare, all these things are similar in most of the countries. Now, general healthcare facilities declined because all the resources were shifted over to COVID. Now, I will tell you about experience of our medical college itself. The whole hospital was converted into COVID hospital, where complete payment has been taken care by the government. And lot of hospitals were overwhelmed with number of patients. Inpatient service compromised to accommodate COVID patients. Outpatient services were transformed. Online and teleconsultation guidelines came up by the government, and we started doing that. Physical attendance to the hospital for psychiatric care were discouraged to prevent the spread of infection. So most of the patients do not wear masks. This is our outpatient during the second wave of the COVID. And you can see that all chairs are empty. And general psychiatric care was compromised, limited availability of psychotropic medication, daycare facilities stopped, residential facilities stopped with new admissions. Some centers discharged all the residents. Staffs in rehab centers were restricted from going outside. During lockdown, residential rehab facilities suffered shortage of food, difficulty in procuring groceries. And this was
Morelli, you didn't share your slides. We can't see your slides.
Which one?
We can't see your slides.
You can't see?
Yeah, you didn't share the slides. Click on the share screen, share slides.
Okay, right. 1 second. The survival on vocational activities like agriculture, horticulture, animal husbandry. Now, this is something important. A lot of people became independent, especially in rehab facilities, because the food is very important for all of them. Now, lockdown and restrictions are relaxed in stages, and infection persisted. COVID-19 precautions in psychiatric patients was a challenge. Psychiatric rehabilitation centers restarted gradually with COVID precautions. And there are a lot of good things which happened. Only 1/3 of the patients could be accommodated at one point of time. Elderly staff members were advised to stay at home. Patients' families suffered since they could not keep them occupied at home. Patients developed symptoms and unusual behavioral problems. Some of them felt that it was good that they were not attending the rehab centers. Short and long stay homes currently sustained in India with family support, and persons who are homeless and mentally ill had the most difficult situation. Among them, some centers maintained good care with no spread of infection. This is something which is very, very interesting to see. Whereas some centers had large number of infected people and patients included for priority vaccination. And we know that all the psychiatric patients, irrespective of the age factor, the government of India has included them as in the vulnerable group. And all these facilities currently have got both the dose of vaccination. And some of the photographs I would like to show at the end of it. 4 months, no new admissions were taken, no discharge or integration with family. That is the center which I am running. New methods adopted to prevent the spread of infection, and we also taught the whole villagers how to wear masks, how to keep distance, and it was very, very effective, especially illiterate people were following exactly what the doctor tells. No entry of outsiders into these facilities, and staff movement were restricted. Strict protocol for quarantine of staff who go out for 3 days. And this is the way our outpatient runs. We have requested the free outpatient service on second Saturday and fourth Sunday to keep the distance, social distancing, and they maintain. And they have to wear compulsorily masks. And nurse will screen them with the temperature as well as give them sanitizer. And this is the way we were doing the consultation on a regular basis with the distancing and wearing protective masks as well as shields. And we have to live with the thing. And Kerala state government provided healthcare for staff, medication from COVID care to rehab centers. This has not happened in all the states. This one state it had happened. No data on persons who are homeless with mental illness during the lockdown. We do not know what has happened to these people who are homeless, and very few of them were rescued, and rescued people were tested negative. Can you believe this might be because of the actual social distance which they have been maintaining? This is one of the centers where all the people who are around 400 in number got infected. This is in the state of Kerala. And the government took over the whole center, and they deployed the government staff with protective measures, including the caretakers were kept there till the COVID situation improved. And this is the way things have happened. And I think that most of the centers, it has been like this. And most of the countries also, it is like that. Unfortunate thing of COVID is that it is in different stages in different countries. See, India never had a third wave. We are expecting that probably sometime January, February. That's the way the government and scientists are predicting. And we are seeing a trend of slowly increasing number of cases. Now today Bangalore is almost like normal, but cases are still there. But everybody is wearing masks, and we have to be careful. In the hospital, we are maintaining social distancing. Now, certain countries are having very high cases now. And for Professor Michael Stark, we are having a post-COVID clinic, and we are also finding this post-COVID syndrome, and definitely there is a difference between the mental health issues and the neurological complications. And we find that 4 to 6 months is the average duration of these patients. They recover. And so that is the one interesting thing. We also can join you in your endeavors. Thank you very much for the patient listening. I think solely I took it.
Colleagues, and I don't think we'll be allowed question time unless the organizers advise differently. But I think our different presentations show how different countries wrestled with the issue, and there are too many similarities. Governments are communicating with WHO, and they did the best possible on the ground. And thanks to Michael Stark for bringing a different perspective and understanding some of the scientific aspects to COVID-19 issues relating to chronic fatigue, comparison with depression and so on. Sometimes it's so difficult to know what you're really dealing with. But I would like to stop here unless Michael Stark wants to make some closing remarks, and then we close the session. If Jenna, do we still have time? Go ahead, Michael.
Corona one of the positive effects is that it really shows us again that we are one world. So that brought us together again to that we only if we transnational get all forces together, then we can fight and combat such a virus or such a things that try to change our lives. And I really envy your countries how good you could organize all the vaccinations, because in Germany we have about 20% of people who are really don't want to get vaccinated because they say it's all a mystical thing and the government wants to control us, and the right-wing parties are taking that over as an argument against the democracy. So it's really a bad problem, and I think your countries dealt with it much better. So again, we are one world, and we will manage, because as so many times we show how we exchange our knowledge and get forward.
Thank you, Michael. Professor Murali wants to say something.
I just want to make one comment. Even though we are the largest producers of vaccine in the world, because the hub of vaccine, a lot of companies produce here, and fortunately we are now the vaccination coverage is much better, but the billions and billions cannot be covered. Now I want to make a statement here. What is that? If all the people across the world is properly vaccinated, this virus is not going to go, and we may have to learn how to live with it, and probably as psychiatrists and mental health professionals, we should be able to give some solution of how to live with it. And that's my last comment.
Thank you. Your last statement, Monique?
Mine is to say thank you for the invitation. Thank you for allowing us to share our experiences. But in summary, we have a silver lining. We have been able to practice telepsychiatry, and I believe this is going to help us reach those who cannot reach the specialists, especially in Africa, where the ratio of psychiatrists to patients is very low. This is going to be an opportunity for us to meet even those who are in rural areas, to work with doctors who are working in the rural areas. And I believe it's a silver lining for COVID. And thank you for the opportunity to present.
Thank you very much. I don't know whether some of our colleagues, Antonio, Maone, do you want to say something?
Good morning. I'm Tammy Bent, and I'm so happy to be able to join you this morning to talk a little bit about the impact of COVID-19 on children's mental health. So just to give you some perspective on the scope of the problem, there are more than 2 billion children in the world, and children make up about a third of the world's population, and a significant percentage of them are between the ages of 10 and 19, but most children are attending some type of school. And so when the nationwide closures happened, it impacted over 90% of the world's children's population. And the pandemic is not over, so we've not yet seen the full effects of this pandemic on us. So I want to just give you a little bit of perspective to help inform your understanding of the discussion that we're going to have today. When we talk about children, it's important for us to remember that we're actually talking about a whole ecosystem in which people live. And this is true for adults, but we sometimes forget about that with adults. But children and all people are impacted by multiple different overlapping systems. So in Bronfenbrenner's ecological theory, Bronfenbrenner conceptualizes individuals as wrapped in multiple systems. Your microsystem is your system that surrounds the immediate person, your family, your school, your friends. The mesosystem is a layer through which other systems interact, your family, your school, your peers, your religion. And then there's the larger systems, such as our economy, political systems, and education that impacts all of us on a day-to-day basis. With COVID affected all of those systems. And so typically, the microsystems are protected by all of the other systems, but in the case of COVID, all systems really kind of fell apart in many ways for a short period of time. Well, why is that relevant? Well, it's relevant for a multitude of reasons. I mean, for all of us, we experience a significant amount of stress, but for children and adolescents, the impact of stress is different. So stress is a normal part of life, and most of us get through that just fine. But with COVID, we had this experience of what was a prolonged and unremitting stressor. And we know that prolonged and unremitting stressors contribute to toxic stress. And toxic stress impacts our brains, it impacts our moods. For young people, it impacts brain development. We know that toxic stress impacts cortisol production. We also know cortisol production isn't the only way that our bodies are impacted by trauma. For young people, trauma impacts brain development by multiple mechanisms. So the frontal limbic circuits, which contribute to threat reactivity, are heightened. And there's weakened emotion regulation. What we see over time with perpetual stress is delayed myelinations, abnormalities of synaptic pruning. Synaptic pruning is how the brain is remodeled over time. And synaptic pruning is particularly robust during adolescent development when, our emotional systems are developing ahead of our control systems, our executive functioning. We also see decreased new nerve cell formation and increased loss of neurons. Essentially, what we start to see is reshaping of the brain in ways that are negative. We'll also see declining hippocampal volumes and increased amygdala reactivity, which is our emotional control system. So children become more dysregulated over time. And so this provides a backdrop to some of the concerns that we have about what's happening to children during the pandemic. So how did COVID impact young people? Well, COVID impacted all of us in so many ways. But specific for young people, I'm going to talk a little bit about the developmental, emotional, social, and academic impacts, which are pretty significant. So I want to talk about the impact of COVID from two perspectives. One was the safety measures that were imposed by COVID. So there were independent effects of the lockdowns, the isolation, and the restrictions that resulted from the need to preserve safety for families. And then there were other effects upon young people who may have already been struggling, who lost access to their clinicians, to their support systems. And then there are the social impacts of the pandemic and how that has impacted development. So the one thing that was true worldwide, based on most of the surveys that were conducted early during the pandemic, that parents and kids agree that COVID-19 itself and the public health measures made everything worse for everyone, especially for young people. But there were different effects of the pandemic on different individuals. And those were heightened by those who were struggling with specific mental health challenges. Some populations were affected more than others. The reality is that many young people will move through this pandemic with limited impact, but others will be affected in long-standing ways. What we also know is that those who were experiencing pre-existing mental health conditions and those who had neurodiversity challenges such as autism, ADHD, OCD, were impacted more by the pandemic than those who had no pre-existing conditions. So what are we seeing as the pandemic has progressed? And I want to preface this talk by saying that there were data that we saw very early in the pandemic. It was wonderful that we started to collect data almost immediately after the pandemic started. But what we're learning is the mental health impacts of COVID is shifting over time. And so I'm going to present to you today some of the data that we collected early, but also some of what we're seeing recently. And much of our recent data confirms what we thought would happen at the beginning of the pandemic. What we saw with younger kids and what we continue to see is a lot of anxiety, irritability, and uncertainty about the future. And this is particularly true for preschoolers. Parents are complaining of disturbed sleep patterns, nightmares, poor appetites, more inattention, and separation-related anxiety. Those were the things that we thought would happen very early in the pandemic. And we started to work with families around how to address those things by providing outlets for supporting kids. What we've observed as the pandemic has progressed is that parents are complaining much more of hyperactivity and conduct problems. Their children just not doing what they asked them to do as they've started to return to school. What we're seeing with school-age youth at the beginning of the pandemic was just less enthusiasm, just less emotional expression, and much distress expressed around the loss of outdoor activities, the loss of their friends, the loss of interactions with their peers. And parents started to observe an increased dependence on parents for structure and engagement. So remember, kids every day had a routine. For many families, especially depending on how many children they had, they couldn't maintain that routine. There was more conflict in the home between siblings, and then for many children, the online learning was a significant challenge absent teacher-peer interaction. And these things had very negative impacts on school-age children. What we're seeing internationally is increased complaints and seeking of mental health treatment for school-age children at higher numbers than we were seeing before the pandemic. There were more reports of depression and anxiety. That has continued to be true across all age groups. But for those who were forced to maintain physical distancing because of COVID, it was worse. And we also have observed a strong correlation between screen time during the COVID and worse mental and emotional well-being. So screen time avoidance was impossible given that most learning rapidly converted to online, but we're starting to see the negative effects of too much screen time for young people that was unsupervised by parents. We also started to observe increased hoarding behavior in teens that were exacerbated by the lockdown. And it was harder to treat, and it has been harder to treat because people are really worried about getting infections. So contamination fears, hoarding, and physical symptoms have worsened for those young people who were struggling with those concerns before, particularly young people with obsessive compulsive disorder. And then what were the effects of the lockdown that we were seeing? And as I mentioned, some of the effects of the safety measures occurred independent of the mental health related issues. So the prolonged quarantines really created a lot of post-traumatic symptoms for kids and persistently a lot of irritability. But there were other impacts of the lockdown that we'll be addressing for a long time. There was decreased physical activity. As I mentioned, the impact of increased screen time, the disruptions to sleep, which contributed to significant dysregulation in other functioning, a lot of peer difficulties and isolation, and then for young people who were developing at the time when mental health conditions have their onset, we saw an increased onset of psychiatric disorders without an ability to respond because of limited access to care. We saw more chronic and acute stress, worries about family health, and unexpected bereavement, which we'll talk about a little bit later. The school disruptions, the social separations, and the increased use of the internet were problematic. For those with pre-existing conditions, there were significant breaks in psychiatric care. Even though we quickly pivoted to telehealth, that was still true. Other things that we're starting to see emerge, things we were concerned about, some of them we actually still don't have current data. So for example, we did not anticipate the impact of loss on specific populations. And so grief happens for young people, but COVID created new circumstances. So for young people who lost relatives, they basically, the last time they saw their relatives, they were well, and the family member disappeared, and the next thing I heard, they had died. And so traumatic grief is what we are seeing and what we can expect to see throughout the ongoing pandemic. The risk of traumatic grief was exacerbated by the inability to see family members, to have rituals to say goodbye. And we also know that traumatic griefs are associated with more mental health conditions among young people, particularly anxiety and primarily depression. We also anticipated greater gender-based and sexual violence because in more child abuse, or maybe not more child abuse, but undetected child abuse because kids were only in one setting. And so caring adults that see children in other settings, such as schools, did not have access to children anymore. And we're still examining that data because that data has not yet been fully presented. Other effects of the quarantine and lockdowns had to do with media consumption, and we're still seeing the effects of that now. So during the pandemic, parents didn't have much ability to control internet and social media use, in part because we counted on the internet for communications for ourselves, for our kids, and for schools. And we know that for some families, the social media was very pro-social because it allowed academic support, learning support. It also allowed continued interaction with families and with peers, with family members and peers. The problem was the consumption without parental supervision. And that included just keeping up with media events, because watching the events unravel about COVID was also very stressful to people without context. But in addition to that, there was an increase in online bullying, which was significant for susceptible youth. So for youth with depression, suicide, or who was struggling with self-esteem anyway, the online bullying was detrimental. Online impacts were especially pronounced for younger children, who most of whom were too young to be doing online learning anyway. We saw more sleep problems and negative effects on youth who were already struggling. And then there were disparities generated by the lack of digital access in many parts of the world, even in developed nations with lots of internet access. But those people living in remote regions, for underprivileged youth, they didn't have access to digital platforms for education. And so we know a lot of those young people have been left behind because they were not actually attending school for much of the pandemic. In addition to the other factors that increase their risk, such as nutritional deprivation, these are multiplied during this pandemic by the social isolation, economic loss, and family loss. And then we also know that kids who live in under-supported communities are at greater risk for a multitude of community traumas and adverse childhood experiences, which increase their risk for depression, anxiety, and suicidality. And this has definitely worsened across the world with the school closures during the pandemic. So what's happening from a mental health perspective during COVID-19? Well, so we saw a lot of early studies, and our early studies were based on questionnaire data that was collected at the beginning of the pandemic, and that most of that data came from the places where the pandemic started first, which was China, and other countries that were early impacted by the pandemic. So, you know, what we saw early on were reports of high rates of depressive symptoms. You know, 22 in the Hubei region in China was close to 23% early on, about close to 20% for anxiety symptoms that were collected by survey, reported by children and parents. Save the Children conducted a survey of parents and child well-being. About 70% of the children and households at the beginning of the pandemic reported concerns about their children's emotional health. About half of the children reported feeling bored or worried, which are frequently proxies for depressive and anxiety symptoms. And then most of the children were worried that they weren't learning enough, and most of them were worried about missing out on social activities with their peers. In other early studies in China and Spain, you know, we observed increased rates of depression, anxiety, increased rates of both. And then we started to see the early impact of the pandemic on girls more so than boys. In Spain, we saw similar results with college students, with 20% reporting moderate to severe anxiety, close to 35% reporting depression, close to 30% reporting stress. But what was most significant is that over half reported that they were experiencing some moderate to severe impact on their emotional health. The other population of young people significantly impacted by COVID-19 has been neurodiverse children. And in that group, I'm defining ADHD, autism, learning disabilities, cerebral palsy, and other challenges. So early on, we anticipated disruption of services, primarily school-based services for those populations, would create significant stress for those families, given that the treatments for most of those conditions really involve a structured school setting. And when we knew that families can't recreate that in their homes, so there was going to be significant disruption, we predicted decreased tolerance for the restrictions and the unsupportive learning environment that was not structured to meet their learning needs. And what we're finding is that's true, that the population of neurodiverse individuals, based on recent data worldwide, is describing poor mental health with severe emotional and anxiety symptoms. And, and basically the factors that limited access to usual services has been problematic for those populations. We also have learned that youth who have chronic physical health conditions, particularly those with respiratory conditions like asthma or cancer or other conditions with immune compromise, have experienced a significant decline in their mental health during the pandemic. And it's understandable because, because of the way that COVID spreads, its respiratory mode of transmission. For youth who are immune compromised and at risk because of infection, those youth were increasingly distressed by the COVID pandemic. But I have to say the benefit and the bright star in all of this really has been that telehealth has allowed us to continue to reach many of those populations. And so that has allowed us opportunities for expansion of access. What we're seeing in the United States is that there's a significant increase in emergency department visits, particularly among adolescents between 12 to 17. And we're seeing over a 30% increase compared with 2019. We're also seeing an increase in suicide-related visits for adolescents in that same age group, and that we're seeing much higher rates for girls, ranging from 26 to 50% of all visits, but the majority of the changes have been for girls. We're seeing girls with increased depression, increased anxiety, increased suicide attempts. And then we're seeing many young people who were previously fine, who had no mental health challenges, who are presenting to emergency departments for ongoing care. So I want to just talk briefly about a recent worldwide meta-analysis that looked at multiple studies with close to 80,000 participants under 18 years of age. And this was a study that was just published a couple of months ago. And the goal was to determine the global prevalence of anxiety and depression among youth. I want to say at the outset that the sample was somewhat skewed, so it was much more represented by European countries and northern countries than among other countries. But when they looked at the prevalence rates, the pool prevalence rates for depression and anxiety symptoms for children and adolescents, they found rates of about 23.8% for depression and 19% for anxiety, which is double the rates that we were seeing prior to the pandemic. We also observed that these symptoms were worse as the pandemic moved on. So at the beginning, we were seeing clinical symptoms. As the pandemic went on, we were starting to see severe symptoms that reached clinical diagnosis. And as I mentioned, more so in girls. We also noticed trends by age. So depression symptoms were higher in older children, while anxiety symptoms were higher across groups. And, we estimated that 1 in 4 youth globally are experiencing clinically significant depression symptoms, while 1 in 5 are experiencing significant anxiety symptoms. The data suggests that the rates are doubling over time and that we should anticipate an increased demand for mental health services. And we're going to need to start planning. When we looked at all the studies, what we found is that there are increased levels of anxiety symptoms across most of the studies. And when we look at broader representation across all countries, the pandemic finds ranges of 8% to 74%. And as I mentioned, it varies by country and it varies by collection mechanisms. Most of the studies, though, that showed the highest rates of anxiety were studies that focused on kids under 12, but they also showed the lowest rates of severe psychopathology. Rates are higher in older youth, and they noted that rates are higher in regions where infection rates were high, and that seems to decrease as the infection rates decline. We're seeing consistently higher rates of depression post-pandemic compared with pre-pandemic rates, and those varied by time from the start of the lockdown to now. and by age. So we're seeing greater impact in older children. We're also starting to see over time higher rates of non-suicidal, self-injurious behavior and suicidal ideation. And just recently, data from Japan has shown significant increases in suicide rates. Now, mind you, in many of these countries, suicide rates were increasing prior to the pandemic. That's definitely true for the US. It's definitely true for Japan. But they increased by 49% during the second wave of COVID. So I want to talk a little bit about, so what can we do about it? Because we're not going to go out and provide individual treatment for every single child that was affected by the pandemic. So what we need to do is promote well-being and health. We can do that by supporting children and their families. So some of the things we've learned about children who have done better through the pandemic is that those children had certain experiences. They had reassurance from competent and caring adults. Those adults also modeled coping and good communication. And those parents also provided appropriate information. They informed themselves and they talked to their children about what was happening appropriately. So even though the parents may have been distressed, they shared with their youngsters that they too were worried about the pandemic, but they knew what to do. We're going to keep ourselves safe and we're going to survive through the pandemic, and this is how we're going to do it. Families who approached the pandemic that way did better than parents who didn't communicate or conveyed panic to their children. Families who maintained routines, sleep, diet, exercise, engaged their children in dialogue about the pandemic, stayed connected with professionals, other community members, and patient education, and then the utilization of teleconsultation assured continuity of care and support for the ones who were struggling with mental health conditions. One thing that was very helpful during the pandemic was green space. So young people who were able to engage in outpatient outdoor activities in green space and adults did better during the pandemic. Protective factors appear to be maintaining daily routines. So families and individuals that stuck with routines, even if they weren't going to school every day outside, who kept with school routines, family routines, sleep routines did better. Families who spent time together in a healthy way did better. Families who had high conflict before the pandemic, who started spending more time together and continued to have high conflict, did worse. Strong parent-child relationships have been associated with better mental health outcomes. Social media use, guided by parents, allowed folks to stay connected with friends and families and buffered those feelings of loneliness and isolation. And then for youth, for minoritized youth populations and for sexual minority youth, telehealth and the internet allowed them to stay connected with supportive peers and organizations. So there are predictive factors that help identify families who will need less support during the ongoing pandemic and beyond. And some of them are internal to the child, some are internal to the family. So the intelligent children with good cognitive abilities, with good emotional and self-regulation skills, religious youth, youth who live in families of faith, youth who feel good about themselves, and kids who have great schools do better. For families that have beliefs and attitudes that facilitate coping. And so it's not just religious families, but families who have core values and beliefs that they stay focused upon. Families who maintain routines and who do a good job of doing that and rituals. Effective communicators, families who are able to absorb information from the community and appropriately convey it to their children do better. And then families who have good problem-solving skills. They're not perfect families, they're flexible and adaptable, but they generally have solved problems well before the pandemic and will continue to do so now. What can we do to support families? Well, we can support connectedness, commitments and shared values, participation in healthcare visits, participation in the community, participations in faith communities. We can help families structure roles, responsibilities for themselves and their children, and we can teach families how to talk to their children for those who are struggling in a supportive and nurturing way. We can also teach parents and children how to reflect critically with mindfulness, thoughtfulness, of being in the moment. And we can provide resources for families and communication about what they can do and how they can access services that they need when they don't know how to access them. And so I just want to summarize by pulling all this together and just saying that, overall, older children and adolescents appear to be struggling more during the pandemic with more depressive symptoms, worry, stress, and fear related to COVID-19 than we're seeing with younger children. We're also starting to see trends towards girls having higher levels of stress and mental health concern and greater declines in their overall mental health. The same for gender diverse youth, who are also experiencing greater declines in mental health. And then we're going to have to deal with the long-term impact of sudden COVID-related deaths. Complicated and prolonged grief are more likely to lead to depression and other psychiatric disorders. And we also know that we're going to need to pay more attention to vulnerable youth, the ones who were deprived of school and external support, minoritized youth populations, girls and children living in poverty are at greatest risk for poor mental health. And it's not because they're poor. I mean, poverty doesn't mean that you have to have poor mental health, but it definitely increases your chances of living in communities where you're much more likely to be exposed to adverse childhood experiences and that you're likely to have difficulty getting access to resources. We should anticipate greater anxiety and depression that we're going to have to address, and we need to recognize that we are just beginning to see the effects of this pandemic because it's not over. Telehealth will continue to be a major tool for us. Telehealth is not a treatment, it's a platform for treatment, but we're going to need it for the future to expand access. And this pandemic is a call to action for all of us, for system level planning to address children's mental health needs now and for the future. And that's the end of my comments. Thank you for your time and attention.